بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله وعلى أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه أجمعين. السلام عليكم ورحمة الله وبركاته. Good morning everyone. Thank you for those who made it for the early morning session. So we're gonna have the today inshallah the last and the second day of the Saudi Digestive Disease Forum for 2023, and we'll be having the best abstract that were submitted to the conference. We will be having 3 oral presentations for the best 3 abstracts. The selection were made by a Canadian university, which is Western Ontario University. So these are based on their selection criteria. We're gonna present today, inshallah, and the authors of those abstracts gonna present 3 oral presentations. We're going to start with the first one, which is entitled The Effectiveness of Short-Term Ustekinumab versus Vedolizumab in Crohn's Disease After Failure of Anti-TNF Agents, which is a single-center experience, a retrospective observational study. Dr. Tokil Amil is going to present this study. And then we'll have a Q&A session. Dr. Tokil Amil doesn't need an introduction. Dr. Tokil Amil is a consultant gastroenterologist in King Fahd specialized hospital in Eastern Province. He's the chairman of the Department of Medicine there. He's an active member in the field of pulmonary bowel disease and gastroenterology. He's heading the scientific committee in the SGA. Dr. Tokil Amil, the floor is yours.
Thank you so much, Dr. Abdulillah, and thank you for accepting the abstract. Our study was led by my colleague, Dr. Lina Al-Hebi, who is a clinical pharmacy resident. Unfortunately, she couldn't make it to the meeting due to academic commitments. We will present the effectiveness of short-term ustekinumab versus vedolizumab in Crohn's disease after failure of anti-TNF agents, a single-center retrospective observational study. So these are my disclosures. Crohn's disease, as you know, is a chronic inflammatory condition that causes inflammation throughout the digestive tract. The latest clinical practice guidelines suggest the use of monoclonal antibodies, anti-TNF, after failure of conventional therapy, and if the patient is refractory to corticosteroids. Despite the effectiveness of anti-TNF, some patients fail to respond to this treatment and require escalation of therapy to another agent, including ustekinumab or vedolizumab, which are thought to be alternatives to anti-TNF after failure of this class. To our knowledge, ustekinumab and vedolizumab have not been compared in a head-to-head trial in patients with Crohn's disease. So our objective in this study was to compare the effectiveness of ustekinumab versus vedolizumab at 12 weeks in treating patients with Crohn's disease who showed no response to anti-TNF therapy. This was a retrospective study looking at patients from King Fahd Specialist Hospital in Dammam. We looked at patients in the period between January 2017 and December 2022. We included adult patients who had Crohn's disease and did not respond to anti-TNF therapy. We excluded patients who were diagnosed with indeterminate colitis or those who have not received anti-TNF agents. Those who responded well to anti-TNF continued on these agents and were not included in the study. The primary outcome was overall effectiveness of treatment at 12 weeks' time and clinical improvement at 12 weeks' time. We also looked at clinical, biochemical, and endoscopic remission rates at week 12. We looked at cumulative corticosteroids use and corticosteroid-free days. We looked at overall treatment effectiveness and measured as ordinal scale at 6 levels, achieved all remission, achieved endoscopic and clinical, achieved endoscopic and biochemical, achieved clinical and biochemical, achieved any single remission or no remission at all. Clinical remission was defined using the Harvey-Bradshaw index. We screened 546 patients. 445 were excluded for different reasons. We included around 100 patients. 70 of them received ustekinumab and 30 vedolizumab. The baseline characteristics were similar between the patients who received vedolizumab or ustekinumab. They were similar at age, the mean of 31 or 32. Duration of disease was around 11 or 10 years. The Harvey-Bradshaw index at enrollment was similar. Serum CRP was also similar, and fecal calprotectin was also similar. We looked at the total use of corticosteroids, the percentage of patients who used corticosteroids was higher in those who received vedolizumab compared to those who received ustekinumab. Prior anti-TNF failure was around 60%, as I mentioned, adalimumab 60% and 40% were on infliximab. The primary outcome, which was an ordinal scale, 1 meaning that the patients achieved all kinds of remission, 6 did not achieve any remission. So the lower the score, the more likely they are to achieve remission. So ustekinumab had a lower score of 4 compared to vedolizumab of 5. So remission rates were higher with ustekinumab compared to vedolizumab at the end of 12 weeks. The adjusted hazard ratio was 0.61 with a confidence interval of 0.26 to 1.35. Similarly, if you look specifically at clinical remission at week 12, the results were better for ustekinumab compared to vedolizumab with a similar confidence interval. The secondary outcomes, including clinical remission, were higher in the ustekinumab group. Clinical response was also more likely in patients who received ustekinumab compared to vedolizumab. The number of days patients spent without requiring corticosteroids, defined as corticosteroid-free remission, was 84 days in ustekinumab patients and 55 days in vedolizumab. So again, ustekinumab did better at week 12 compared to vedolizumab. So the study showed that ustekinumab was associated with superior therapeutic outcomes compared to vedolizumab in achieving lower Harvey-Bradshaw index and higher rates of clinical and biochemical and endoscopic remission. It was associated with significantly increased probability of having corticosteroid-free days and lower cumulative corticosteroid doses. The study didn't achieve statistical significance, so in contrast to network meta-analysis, we couldn't show clearly that there was overall benefit to ustekinumab. The trend was better to ustekinumab, but the p-value was not statistically significant. That's probably related to the sample size. So the main strength of our study was that it's the first, to our knowledge, to evaluate the effectiveness of these agents in the short term in a population in the Middle East. It was also the first in this region to report an overall effectiveness of these agents. Our study was limited by the fact that it was a retrospective observational study. We recruited patients from a single center. The target sample size was not reached, and we couldn't get the baseline simple endoscopic score of Crohn's disease, which would have been an important factor to look at. And we had missing endoscopic findings for some patients. So to conclude, Mr. Chairman, among Crohn's disease patients who failed anti-TNF therapy, ustekinumab was more effective than vedolizumab in all tested outcomes. We think that the real-world insights help us determine treatment's relative efficacy in managing Crohn's disease patient. However, this does not substitute for randomized controlled trial and prospective studies that are crucial to further validate these results. Thank you so much.
Just one question, Dr. Al-Amil. Now, regarding the exclusion criteria, you excluded patients who were primary responders to anti-TNF. What was the rationale behind doing so?
So we thought we want to specifically look at patients who failed anti-TNF. Our practice has some patients who were switched away from anti-TNF for other reasons. Suspected, for example, demyelinating disease or lack of access to the medication. Some of them from remote area couldn't, for example, access the infusion unit to get infliximab. So they didn't meet our criteria where we're looking specifically at the population where anti-TNF failed rather than stopped for other reasons.
Okay, I thought because it was exclusion refractory patients with Crohn's disease, I thought you excluded that. Now, another question, if there is no other questions as well from the audience, is regarding as well the sample size. You had difficulty recruiting more patients. Was there any reason for that?
Yeah, so when we applied it was a retrospective study, and when we applied the inclusion and exclusion criteria, it was lower than what we hoped for to show statistical significance. And I think it's just the reflection of the number of patients we have is not large enough to conduct this study.
So if there's no more questions, I would thank Dr. Al-Amil for his nice presentation, and I would invite the second presenter. So the second oral presentation that was accepted is from Prince Attam University in Al-Kharj. Doctor, I would invite the second presenter, Dr. Majid Bahadra, for presenting the second abstract, which is entitled Detection Factors Associated with Pre-Malignant Stomach Lesions and Surveillance Among Individuals with Positive Fecal Occult Blood Tests and Negative Colonoscopy, a 6-year multi-center prospective cohort study from low incidence central Saudi Arabia. Dr. Majid, the floor is yours.
Assalamu alaikum. Assalamu alaikum, everyone. Good morning. I'm Majid Bahadir, internal medicine resident from Dr. Sulaiman Al Habib Medical Group. Today I'm going to present our article which entitled Detection Factors Associated with Pre-Malignant Stomach Lesions, Surveillance Among Individuals with Post-Fecal Occult Blood Test and Negative Colonoscopy. It's a 6-year multi-center prospective study, cohort study from low incidence in central Saudi Arabia. In the beginning, few data are available in the endoscopic assessment and surveillance of precancerous stomach lesion. Also, international guidelines recommend the surveillance of such precancerous lesion. However, it's difficult to define high-risk factor for gastric cancer. At the moment, these high-risk factors, including being male, smoking, having pernicious anemia, helicobacter infection, and or having family history of gastric cancer, along with subjected to follow-up for PSLS. The chorea cascade is a model for histologic progression. The progression of PSLS is not fully understood, but we have this cascade which describes the progression. Infection with H. pylori is the most common etiological environment, the factor that participates in the cascade. However, little is known about the PSLS and how such lesion can further progress to dysplasia and eventually to gastric cancer. So the progression of normal mucosa to chronic, this scheme showed the progression of normal mucosa to chronic gastritis, atrophic gastritis, intestinal metaplasia, then dysplasia, and eventually gastric cancer. There are multiple risk factors, including H. pylori, which is the most common etiological factor. In low incidence countries, there are few data in the endoscopic assessment and surveillance of PSLS. However, lack of data may negatively influence the yield of surveillance. Studies varies in the duration of pre-malignant stomach lesion surveillance, time interval in high, intermediate, and low-risk countries. Our country, Saudi Arabia, has a low incidence of gastric cancer. However, there is no data available for pre-malignant stomach lesions, prevalence, precursor of gastric cancer, and risk factor possible for pre-malignant stomach lesion. Therefore, the aim of our study is to identify precancerous stomach lesion and examine the progression and the risk factor associated with pre-malignant stomach lesion in people from 45 to 70 years old. So the material method, tissue sampling was performed selectively when abnormal mucosal findings were observed during endoscopy using chromoendoscopy followed by biopsy. Epstein-Barr virus was detected in tumor tissue by in situ hybridization and by immunochemistry. So we exclude the people without accessible health record or move out of Riyadh during the observation period, or people with history of gastric cancer, non-PSLS, and other upper GI symptoms. So these tables show the baseline characteristic of study participant. The first part reveals the demographic distribution, including the age group, gender, education, monthly income, BMI, smoking status, food, and family history of gastric cancer. This table shows the highly analytical association between developing gastric cancer and Helicobacter infection. And 1/3 of the participants showed that they have pre-malignant stomach lesion with chronic gastritis with 63%, chronic atrophic gastritis 8.6%, intestinal metaplasia with 16%. So this table shows the baseline characteristic of the analytical association between the factors and the PSLS with high significant values of with negative predictive values of gastric cancer, and age group between 66 to 75 years, obesity, low education level, and type of food consumption, with predictive value less than 0.001. So in the conclusion, the 6-year prevalence of PSLS was almost 1/3 among patients with positive fecal occult blood test and negative colonoscopy in central Saudi Arabia. Also, that the participant rate was high, 87%. Furthermore, the neoplastic progression was 0.4 per year, with almost similar to other low incidence countries for gastric cancer, like Netherlands and Norway, with 0.3%. These factors may reduce the risk of PSLS, including H. pylori eradication, normal body weight, not smoking, and adhering to a healthy diet can reduce the risk. Also, gender is not a risk factor as in other studies. The most importantly, screening for PSLS among patients with positive fecal occult blood test and negative colonoscopy may prevent progression to gastric cancer or result in the early detection and effective treatment of gastric cancer, reducing high mortality rate due to delayed diagnosis. At the end of my presentation, I would like to thank SGA for accepting our abstract, and special thank you to Dr. Al-Badrani, and thank you for your time.
Thank you so much, Dr. Majid. So do you think if we included a larger population from across the kingdom, we'd have different results? Especially the impact, for example, of gender. Do you think we're more likely to see precancerous lesion in men than women?
Actually, upon our studies, the study showed there is no significant changes between gender, male and female, in central Saudi Arabia.
And just another question from my side regarding the utilization of positivity of fecal occult, blood test in the stool with negative colonoscopy to kind of like having a pathway to perform a screening upper GI endoscopy, correct?
Yeah.
So when you presented that, do you think these data that you presented is enough to make such recommendation? Like, shall we really utilize the FOBT outside of its approved indication? So we tend to use the FOBT for screening for colon cancer. It's not yet validated to be used to screen for gastric cancer or pre-malignant stomach lesions. So what do you think we can utilize the FOBT in such patient population? I hope the question is clear. So FOBT for gastric cancer screening, are we there yet?
No, actually we use fecal occult blood test as a screening, then we use the endoscopy and followed by biopsy to confirm the diagnosis of the gastric cancer.
So we maybe too early to endorse such conclusion, right? So I will not maybe force every patient who is positive FOBT to go for an upper GI endoscopy screening yet, maybe because of the low prevalence of gastric cancer in our country, and as well the high false positivity rate of such testing. So maybe further data would be nice to collect more sensitivity and accuracy data of such test before endorsing such conclusion.
Sure.
Okay. Sure. Thank you, Dr. Majid Bahadur, for this presentation.
Thank you.
If you can just put your hands again for Dr. Bahadur for his presentation again. And
Third abstract this morning is a abstract from King Faisal Specialist Hospital and Research Center, looking at the comparison of upadacitinib induction in tofacitinib exposed and naive patients with inflammatory bowel disease, a real-world multi-center study. This abstract by research group from King Faisal, and the presenter will be Dr. Ibrahim Al-Umar, who is starting his third-year fellowship in gastroenterology in January. Dr. Ibrahim, you have 7 minutes. Thank you.
Assalamu alaikum, good morning. So first, thank you for accepting our abstract. So I'm Ibrahim Al-Umar, GI fellow at King Faisal Specialist Hospital. I will be presenting research titled Conversion of upadacitinib induction into tofacitinib exposed and naive patient with inflammatory bowel disease, a real-world multi-center study. So background, upadacitinib is a selective Janus kinase 1 inhibitor recently approved for treatment of ulcerative colitis and Crohn's disease. Patients with non-selective JAK exposure were excluded from upadacitinib clinical trials. It is unclear if previous exposure to non-selective JAK inhibitors such as tofacitinib impact the response rate to obadasitinib. The aim of this study were to compare the clinical outcome of OBADA induction in inflammatory bowel disease patients with and without previous exposure to tofacitinib. Material and method. So this is a multi-center consecutive patient with diagnosis of inflammatory bowel disease. Patient must receive obadasitinib from 1st of January 2022 till 6th of January 2023. The outcome were assessed at week 4, week 8, and week 16 post-OBA induction. The primary outcome were clinical response as defined by the physician global assessment and steroid-free clinical remission. The secondary outcome were normalization of CRB as CRB less than 5 and normalization of fecal calprotectin of FCB less than 250. The outcome were compared between patient naive and exposed to tofacitinib. So the results, so a total of 36 patients received obadasitinib were included. So ulcerative colitis in 75% of patients, Crohn's disease in 19.4, and IBD unclassified in 5.6. The median age were 30 years and 52% were male. All patients received 45 milligram as induction dose, except one patient started on 30 milligram. Extended induction to 16 weeks were necessary in 33% of patients. OBADA induction outcome will be shown later. A total of 9 out of this cohort were previously exposed to tofacitinib. In this cohort, 66% who had diagnosis of UC, and 22 Crohn's disease, and 11 with IBD unclassified. Extended induction beyond 8 weeks were necessary in 33% of the total number. So this table is showing the baseline characteristic of the patient, as we mentioned, the age and the gender. This is the IBD subgroups. And as expected, most of the patients had previous exposure to biologic. And the mean number of biologic were 2. So this is obadasitinib induction outcomes, and as you see in the graphs, so each category is defined by the clinical response, steroid-free remission, normal CRB, and fecal calprotectin with a different color indicating the time interval. So we can see for the clinical response at week 4, 93% achieved clinical response, and as so for week 16. Steroid-free clinical remission, 41% achieved at week 4. However, 68% achieved steroid-free remission at week 16. Normalization of CRB, as we see, is 50% by the week 16, as well as the fecal calprotectin with 33% at week 16. This is the special comparison between patients who have been exposed to tofacitinib and tofacitinib-naive patients. We can see the clinical response at week 4. It was 95% in tofacitinib-naive patient, where it was 88.9% in tofacitinib-exposed patient. Steroid-free clinical remission were 45% in naive patient and 33% in tofacitinib-exposed patient. I will go to week 16. We can see the clinical response in naive patient were almost 90%, and in the patient who has been exposed to tofacitinib were 83%, and also steroid-free clinical remission were 63% in naive patient and 83% in tofacitinib-exposed patient. So regarding the safety, so a total of 9 adverse events were related to obadasitinib. 1 patient developed transient leukopenia. 1 patient developed herpes zoster, which was on 45 milligram dose. 7 patients developed dyslipidemia. None of them required initiation of statins. 1 out of 9 patients who have been exposed to tofacitinib developed adverse event, which is the dyslipidemia. None of the adverse events require discontinuation of obadacitinib. So the conclusion of our study, so obadacitinib resulted in steroid-free clinical remission in half at week 8 and 2/3 at week 16 of patients with inflammatory bowel disease. A clinical response and remission rate during induction with obadacitinib were similar in tofacitinib-exposed and naive patients with inflammatory bowel disease. Our study is limited by the small sample size and lack of biomarkers data. A prospective collection of data is currently ongoing. And thank you.
Thank you so much, Dr. Ibrahim, and the floor is open for questions. If I may, I would like to start with a question. You assessed clinical response by the physician global assessment. Was there a reason not to use the Harvey-Bradshaw index or the partial Mayo score or the simple clinical colitis activity index?
Okay, so the reason for doing, because when we looked back into our patient in the follow-up, we didn't have a clear the full subgroups that to calculate the Harvey index or even the Mayo UC. So we decided to use the Physician Global Assessment because we thought this will be applicable to all our patients in the clinic visit, because you know the type of study it was mainly it's retrospective. So this is what we can get from the patient records.
Any questions?
Thank you, Ibrahim. Do you think it would be wise as well, maybe in the future presentation of the continuation of such data, to include maybe endoscopic outcome? And are we looking into this or not?
Okay, so actually we are looking to another two endpoints, which is the endoscopic healing and also radiological healing. So this is the interim analysis that we did it in June. We are hoping in the next 1 or 2 months we will have the endoscopic and the radiological findings, and then we will update our data and our abstract. So yes, this is one of our target.
Okay, thank you so much. So this concludes our best oral abstract session, and we'll have 5 minutes, start at 9 a.m. the endoscopy session. Thank you.
Good morning, everyone. I know that most of you did not enjoy the game last night, but I hope that you all enjoyed the first day of the SGA-SDDF 2023 and all the courses and workshops that have been running in parallel. The first session this morning is dedicated for advanced endoscopy, and it is my pleasure to co-chair this session with my colleague Dr. Nawaf Al-Utaibi from King Fahd Medical City in Riyadh. My name is Majid Al-Sahafi. I'm from King Abdulaziz University here in Jeddah. The first session or lecture this morning is titled Pancreatic Cyst Evaluation and Management. It is my pleasure to introduce Dr. Abdullah Al-Shahrani, who is an assistant professor of medicine and advanced endoscopy consultant at King Khalid University in Abha. He's also a consultant gastroenterologist at Asir Central Hospital. Dr. Abdullah, the floor is yours.
It's a pleasure to be presenting at this wonderful event. I'll be talking about pancreatic cysts. So I have no financial disclosures. These are my objectives. We'll try to briefly describe the pancreatic cysts and their different types, as well as elucidate some of the high-risk features that we see in those cysts. And then we'll try to discuss some evaluation methods and probably briefly go through management. So how common is it? Historically, the asymptomatic pancreatic cysts were actually found to be ranging from 0.2% on ultrasound to 24.3% on autopsy reports. However, incidental pancreatic cysts on MRI were found to be 13.5% in a study that was done by Karen Lee in 2010. But they did notice that there was a significant difference between the incidence of pancreatic cysts among age groups. Another more recent systematic review and meta-analysis was done by Zerboni and colleagues and pancreatology in 2019, and they showed that the pooled prevalence was more likely to be around 8%. But there was a considerable heterogeneity in the prevalence that they noted. Here's a diagram showing that the cumulative incidence of pancreatic cysts increases with age. And on the right side, you can see that the age bracket significantly increases with age. Here's a more detailed table showing that the prevalence or incidence of cysts is less than 1% in those who are younger than 39 years of age, but increases significantly once you reach 70. So it's more than 40% by that time. Does that mean that cancer increases because we're detecting more IPMNs or pancreatic cysts? Thankfully, no. So you can see the green line showing that the pancreatic cyst prevalence is going up, but the incidence of pancreatic cancer is relatively stable. Are those who have pancreatic cysts more likely to die of pancreatic cancer? And is that the concern that we usually have? There was a study that was done by Anand and colleagues looking at 7,211 patients from US veterans, and they found that there was a 1.1% chance of getting pancreatic cancer. So out of those 7,211 patients who have had pancreatic cysts, only 1% developed pancreatic cancer. How about death? Is it a leading cause of death? Thankfully, only 3.3% of them died because of cancer. 25% or a quarter of them actually died of non-pancreatic cancer. So colon cancer was more likely to kill those patients rather than pancreatic cysts and pancreatic cancer. So what are the different types of pancreatic cysts? There are different classification schemes. These are the two of the most common ones, either neoplastic versus neoplastic. Neoplastic incorporates MCN, IPMN with its different types, solid pseudopapillary neoplasm, as well as cystic degeneration of pancreatic neuroendocrine tumors. And you can have non-neoplastic cysts that includes simple cysts, pseudocyst, and serous adenoma. The one that we usually commonly use is the differentiating mucinous versus non-mucinous classification. Here's a schematic that shows a side branch and a main duct IPMN, both as a diagram as well as imaging and MRCP. IPMN, we have three types: main duct, branch duct, and mixed. The most common is the branch duct, and it harbors the risk of malignancy the least, thankfully. The lowest or the rarest of them all is the main duct, but it harbors the most significant risk to progression into cancer. Here's a branch duct with a mural nodule as it appears on MRI and endoscopic ultrasound. This is an IPMN with a solid component as seen on the MRI and endoscopic ultrasound. And you can see on the right the wall has a mass within it. MCN is almost exclusively in females. 95% of the time it is in females. It happens in the body and tail of the pancreas and has no communication with the PD. MCN can be septated, as you can see here, and the other type is going to be serous cystadenoma. So serous cystadenoma is more commonly seen in women in their 50s. It has a microcystic appearance with honeycombing. A central scar is seen in 30% of the time. It is specific but not really sensitive, so if you see it, it really signifies that it is most likely serous cystadenoma. If it's not there, it doesn't mean that it's not. The good thing about the serous cystadenoma is that it harbors no malignant potential, so we don't need to do any kind of surveillance. Solid pseudopapillary neoplasm is actually present in females in their 20s, and it can be quite large. If it's small, it's mostly solid. If it's large, then it is more likely to be cystic. So there are other types that are very rare, like a simple cyst with epithelial lining, a lymphoepithelial cyst, and a mucinous non-neoplastic cyst. So they have no malignant potential, so we don't really do any surveillance for them. There's a table that summarizes the different types of pancreatic cysts with their respective malignancy potential. And you can see here that the MCN and the IPMNs, as well as the solid pseudopapillary neoplasms, have a high risk of malignancy. So how about symptoms? So obstructive symptoms are usually easy to find out. If there's a pancreatic cyst at the head of the pancreas with biliary ductal dilatation and jaundice, then it's easy to find out. However, whenever someone comes in with a nonspecific abdominal pain, then it's quite challenging to determine whether it's related or unrelated. Most of the time it's unrelated. Bear in mind that pancreatic cysts can cause acute pancreatitis, especially in those who are older than 40 with no other identifiable risk factor. How do we diagnose them? MRI, MRCP is the test of choice usually for detection and evaluation and surveillance afterwards. It has no radiation, it's non-invasive, and has a good or greater accuracy at determining the communication with the PD. Pancreas protocol CT scan and EUS are alternatives to MRI in those who cannot undergo MRI, either because they're claustrophobic or they have implantable devices that are not compatible with MRI. Indeterminate cysts on initial imaging, you can use alternative imaging and or EUS with FNA to try to evaluate it further. The diagnostic accuracy of MRI, MRCP, EUS, and pancreas protocol CT scans are similar. Of course, without the FNA, if we take that into account, then EUS with FNA is more superior. So what do we have to evaluate those cysts other than imaging and characteristics, features on imaging? We have cyst cytology, CEA, glucose, DNA-based molecular testing. We have through the needle microforceps, and then needle-based confocal laser endomicroscopy. So cytology, unfortunately, the utility is limited by the acellular or hypocellular samples, which can be overcome partly by rapid on-site evaluation to tell you if you have a sufficient sample or not. And then a classifying diagnosis, whether the cyst was mucinous or non-mucinous, was only obtained in 31%, unfortunately. So you're missing out on almost 2/3 of your patients if you rely solely on cytology. However, if it's present, it's very specific and it's very helpful. There was a systematic review and meta-analysis that showed that the pool sensitivity was 54% and specificity was 93% with higher sensitivity for high-grade atypia or malignancy. So CEA was first introduced in 2002, and there was a publication by Brugge in 2004 where they chose a cutoff of 192 to maintain balance between sensitivity and specificity. And then there was a meta-analysis that looked into patients and the ability to differentiate mucinous from non-mucinous cysts. And they had a pool sensitivity of 63% and specificity of 88% with an area under the curve of 79%. There was a more recent study that was published a couple of years ago by Imad Khan and colleagues, and they found actually that the area under the curve might be better than we had initially thought, so about 89%. The more popular these days test is the intracystic glucose level, and a meta-analysis was done to evaluate the ability of the glucose level to differentiate between mucinous and non-mucinous cysts, and they found that the pool sensitivity was 91% with a specificity of 86% and a overall diagnostic accuracy of 94%, so significantly better than CEA. This is a study that was done by Zach Smith and his colleagues, published a year ago or last year, where they looked into different levels of glucose in the cyst, as well as the comparison whether you combine glucose and CEA, whether that improves your accuracy. Interestingly, using glucose level by itself has a really good sensitivity at 95% almost. But once you combine it with CEA, then the sensitivity drops significantly. Overall, it seems that if you're going to use glucose, and it has a better diagnostic accuracy. How about next generation sequencing or genetic testing? And you can see that there are tests that you can do to run it on the cyst fluid and determine if they have certain gene mutations that are more commonly associated with different types of cysts. And a meta-analysis was done by McCarty and colleagues, published a couple of years ago in GIE, that showed that the pool sensitivity of KRAS combined with GNAS for IPMNs were 94%, and a pool specificity was 91% with a diagnostic accuracy of 97%. However, if you're trying to figure out if the cyst was mucinous cystic neoplasm, then it was similar to CAA. So it's very helpful in IPMNs, maybe not so much in other types of mucinous cysts. Another modality that we can use is the through-the-needle microforceps, or Moray. It's basically trying to get a 19-gauge needle into the cyst and then passing through it a microforceps and trying to grab a tissue from the cyst wall itself and then sending that for evaluation. This is the sample that comes out. This seems to be a very decent sample. Not always we are able to get that. This is zoomed and magnified significantly. So how does it perform? The technical success was really high, 98%. The histological accuracy for pancreatic cystic lesions, so it's able to differentiate between different types of lesions in 86% of the time. The diagnostic yield was almost 70%. Overall, it was limited by an adverse event rate of 8.6%. With significant heterogeneity in the reported adverse outcomes. So different studies ranged from 1 to 3% adverse event rates, which include acute pancreatitis, which is the most feared one, intracystic hemorrhage, as well as infection. So here's a table that summarizes most of the tests that we have at our disposal to evaluate a pancreatic cyst. Starting from the string sign, which is more than 1 centimeter string between your fingers that lasts more than 1 second. That means that it's very mucinous and very sticky, and that has a very high specificity for mucinous cystic lesions. And you can see the specificity and sensitivity of the tests that we have previously talked about. Another thing that we can do is the needle confocal laser endomicroscopy, where we try to go in to the cyst with a 19-gauge needle, and then a probe goes in after we inject a fluorescent dye, and then we look into the cyst wall and evaluate the pattern that we have in there. And you can see on the left, it's a serous cystadenoma pattern. On the right, there's papillary projections that are more representative of IPMNs. So how does it perform? It really performs well. The pool sensitivity is 85 and specificity of 95%, or 99%, I'm sorry, with an accuracy of 99%. However, the risk of post-procedure acute pancreatitis was 1%. The issue with it is it has a learning curve to determine and recognize the different patterns of pancreatic cysts and their wall. Okay, so now we found a cyst. Now what? So usually whenever we get a patient with pancreatic cyst, we have to determine whether they are a surgical candidate and they are interested in surgery. If not, then just leave them alone. There's nothing that you're going to do that's going to change their management, so it's going to be a waste of healthcare resources. If they are a patient who's willing to undergo surgical resection, then a few guidelines have been developed. Unfortunately, because of the time limitation, I'm not going to go into details. However, I have a disclaimer that these guidelines do not apply to patients who have had a family history or a genetic mutation that predisposes them to pancreatic cancer. So these are only for patients who are average risk. So how do we know if IPMNs progress to malignancy? There have been a few studies that looked into it. One of them classified IPMNs into low risk and high risk IPMNs. Low risks, they were found to have a progression of 0.2% over a year, and then 7% at 10 years. However, if they are low risk IPMNs, then the risk is significantly higher, with 1.95% at 1 year and then almost 24% at 10 years. There was another study that was done by the Japanese group that they found that 3.3% was the risk at 5 years, 6.6 at 10 years, and then 15% at 15 years, and they were only the IPMNs that they evaluated and looked at. The risk of progression in asymptomatic pancreatic cyst to pancreatic carcinoma in general, 5-year cumulative risk was about 2.1%. The annual progression rate was found to be 0.4% per Schweber and colleagues in pancreas a couple of years ago. So are all cyst features the same? Do we worry about them the same? No. So Anand and colleagues looked at cyst features and their risk of progression to cancer, where they went and looked at more than 10 years worth of data from 1996 to 2011 and beyond, and they tried to find who have had surgical resection and who had their cyst features more consistent with malignancy, and they found that the cyst size of more than 3 centimeters was the biggest risk for cancer. They had an odds ratio of 62.4. Mural nodule was then the next most fearsome risk of 9.3, and you can see main duct dilation of 7.2, and main duct as compared to branch duct had an odds ratio of 4.7. So whenever you talk about surveillance risks and benefits, you have to make sure that you're fully aware of your risks and benefits. Risks, you have an overall survival and surgical mortality risk that you're going to be jeopardizing the patient. You know, Whipple, for example, has a 2% mortality and 30 to 40% morbidity. You have to think about procedural complications, financial burden on the system and the patient, and the psychological impact of having that cyst surveillance. Benefits, you can detect high-risk features earlier. You can have a timely resection of high-risk features. You can have some reassurance for the patients. Unclear benefits, however. Whenever you try to get a patient into surveillance program, there are multiple guidelines that have talked about it, starting with the International Consensus Guidelines in 2006 that was revised in 2012, and then in 2017. The Europeans came out in 2013 with their guidelines and updated it in 2018. AGA in 2015, which had more restrictive or conservative management, and then the ACG had their guidelines in 2018. There are other guidelines from the radiological societies, but I'm not going to get into it. Because I want to make sure that you recognize the pancreatic cyst concerning features. These are the high-risk stigmata. Whenever you see them, you get really worried about the risk of cancer or high-grade dysplasia within the cyst. So obstructive jaundice secondary to the pancreatic cyst because it's causing symptoms and
1 minute left.
Compressing on it. And then an enhancing mural nodule that's more than 5 millimeters, dilated main PD that's more than 10 millimeters, and then these are the worrisome features that you have to think about whenever you're evaluating the pancreatic cyst. Thank you very much.
Thank you, Abdullah, for the amazing, actually, talk and comprehensive about the pancreatic cyst. So for the sake of time, we will delay the question till the end of the session. So, Abdullah, can you join us? So it's my honor to introduce our next speaker who came from far, Dr. Ahmed Bizarbash. He's an intervention endoscopist and assistant to professor of medicine at Washington University in St. Louis. His clinical and research interest focus mainly in endohepatology and intervention, US-guided vascular intervention. So Ahmed, welcome, and the floor is yours.
Thank you very much. Thank you to the Saudi Gastro Society, to the moderators, the president, and to the organizing committee, and to my dear colleague and friend, Dr. Ayman Mahadib, for the kind invite. I've been extremely impressed with the conference, and I'd love to make it again here one more time in the future. I have big shoes to fill after Abdullah Shahrani's outstanding presentation, but I'm excited to tell you everything I know about interventional endoscopy and gastric varices. I have no disclosures pertaining to this talk specifically. I'm hoping that I can teach you a little more about the prevalence and incidence and risk of bleeding of gastric varices, classification system as a quick reminder, what endoscopic therapies are available currently, and what do we have in our armamentarium as an interventional endoscopist. Many of you know about this concept of endohepatology, which is this new and upcoming branch of interventional endoscopy, where we perform advanced endoscopy for the management and diagnosis of liver disease. And one of the hallmark features is EUS-guided vascular therapy that's kind of fallen into one of the biggest concepts of endohepatology. When it comes to gastric varices, they're rare, and that's why they don't really get as much attention as esophageal varices. They account for about 10 to 20% only, but the problem is they are higher risk of bleeding, they're much more difficult to manage, and they're associated with a higher mortality rate. And despite all of this, they really fall down the pecking order. You don't really see as well-established guidelines like you do for esophageal varices. In fact, if you go over AASLD or EASL, all the guidelines talk so much about esophageal varices, and then you'll have 1 or 2 lines about gastric varices, and that's purely because the data isn't as robust. I want to remind everybody about the causes of gastric varices. Obviously, the most common is portal hypertension and cirrhosis, and that's what you should keep your eye on. These patients are shunt dependent. As you guys can see, there's a gastrorenal shunt that's usually feeding into these varices. But as we treat more and more patients with pancreatic cancer, we're seeing a rise in gastric varices that happen from splenic vein thrombosis. This is a non-shunt dependent gastric varices, and that's important because our colleagues in interventional radiology sometimes have limited options to treat these patients, and we as gastroenterologists might have a bigger role. Classification of gastric varices is complicated. Almost every group has tried to come up with their classification, but many of us use this one main classification system called the Sarin classification system. It's quite straightforward. Usually look for either GOV or IGV, and I'll tell you my methodology in approaching this. The main key thing is if this is a gastroesophageal varix type 1, and these are varices that extend along the cardia or the lesser curve, treat these as esophageal varices. They are managed normally like banding and other interventions you do for esophageal varices, and shouldn't be managed like the rest of the gastric varices you see. So what I do, and when I'm with my fellows scoping, I'll tell them what kind of varix this is, and usually they'll go on Google and try to remember the criteria, which is very difficult. But what I first do is, are there esophageal varices? If you see esophageal varices, you've immediately gone towards the GOV1 and GOV2. If you don't, it's an IGV1 or an IGV2, which is an isolated gastric varix. When you see one or the other, then the next question is, are the varices in the fundus? Are they sitting up at the top near the GE junction? If the answer is yes, it's a GOV1. And if it's yes without esophageal varices, it's an IGV1. And then if they're not within the fundus, they must be a GOV2 if you have esophageal varices, or an IGV2. So it's extremely rare to see an IGV2. For example, if you see a varix in the duodenum, that's an IGV2. And so if you follow this criteria, you should usually know what you're seeing during the endoscopy. But it's not very easy. A new paper came out from the AGA to kind of simplify things, and they said, you know what, let's not make it as complicated. Let's just break it into 3 groups: cardiofundal varices, which are IGV1 and GOV2, or GOV1s, which are the ones we always banned, remember that, or IGV2, or what they call distal gastric varices. So they tried to simplify it into 3 groups: cardiofundal, lesser curve gastric varices, and distal gastric varices. And if you follow this, usually you'll know how to manage these patients. The interesting thing is, how good are we in diagnosing gastric varices? And when I was a fellow in Boston, I wanted to do this study to see how good we are. Because usually you call someone in the room and they're like, I'm not sure, is this an IGV, is this a GOV? And so we did a survey in Boston across the 5 academic medical centers in the city. And we sent them pictures of gastric varices, and we told everybody, hey, tell us, what do you think these are? And in reality, we didn't really do that well. We had 85 respondents, but only 20 felt very comfortable with what kind of gastric varix they were looking at. In fact, the most incorrectly identified gastric varix was GOV type 2. And surprisingly, our colleagues in hepatology weren't much different than how we were as general gastroenterologists or interventional endoscopists. So clearly, we need more work to better understand these and practice how to classify them. I want to talk a little more about gastric variceal management, and that's why I'm here to talk about interventional endoscopy. But many of you know, and many of you probably do this, but the mainstay of therapy, and this is what guidelines recommend currently as the landscape change, is direct endoscopic injection therapy, using a needle to inject something into the varix to promote thrombosis. Majority of times this is glue, it could be thrombin, it could be some other injectate. Oftentimes you have to mix this with lipiodol to prevent early polymerization. And it works very well. The problem is it comes with its complications and its limitations. So immediate hemostasis is usually up to 100%. The problem is obliterating the gastric varix, preventing it from rebleeding, isn't that high. And so we need more work on this. Some people in the US have started to use a Doppler probe where you Doppler, inject, and then Doppler again, and maybe you can use that as a marker of variceal obliteration. What are the problems with injecting glue or cyanoacrylate? We don't really have much access to it in the US because it's an off-label, non-FDA approved medication for gastric variceal injection. But it comes with its problems if you are using it. The risk of bleeding isn't low. There's systemic embolization. In fact, they've done studies where they did CT scans just for normal asymptomatic patients after glue was injected, and 50% of patients had evidence of showering in their lungs and other organs. It's not clinically significant, but 50% had evidence that the glue had traveled elsewhere. One of the concerns we have is if you're not quick, you may de-roof your gastric varix. You'll put your needle in, you'll inject some glue, and you'll take out your needle and you're de-roofing your entire gastric varix. And now you're dealing with a much worse bleed than the one you started with. And then the last thing is, our scopes are expensive. If glue gets into the channel, you could lose your 30, 40,000 endoscope, and people in the endoscopy unit won't be very happy with you. So it is damaging to endoscopes. So what have we been doing differently? We've noticed that we're very good at EUS. You could see almost every structure through the stomach, so why can't you see gastric varices? Well, in reality, you can, and they look quite pretty. The lower picture here shows you a nest of varices with nice Doppler flow, and that's what you want to see. There's this concept now that you can assess the gastric varix with ultrasound, and that's what we call EUS variceolography. Where does it start? Where's the perforator vessel? How do I approach this? How big are they? And so people started to use EUS and inject cyanoacrylate through EUS. And the data is it is far more superior than doing direct endoscopic injection therapy. And so consider this if you have EUS expertise, because it does give you some better insight into your gastric varices. That said, the problems of using glue are still there. You could still damage your scope, you could still de-roof, you could still rebleed. So it's fixed a small problem, but the bigger overall issue is still there, unfortunately. And so this is where the big player came into play. And this isn't something new. This is what our colleagues in interventional radiology always do. They use coils. And so we thought, hey, if they're using coils, why can't we use coils? We can access varices with our needles. There's no reason why we can't use coils. And this is how this concept of EUS-guided coil therapy came to play. We use IR coils. These aren't coils made for us. They're used for our colleagues in IR, but we're lucky enough that we can load this onto our EUS needle. They're made out of nitinol, and there are small projections that are sort of finger-like projections, as you guys can see in the picture. These are very thrombogenic. Once it comes in contact with blood thromboses immediately. And that's the whole concept of why we want to use this. So it's recently emerged, probably over the past 5 to 10 years. And I'll show you an interesting study that we did about who's doing this in the world recently. The company is Cook. I'll show you a picture of the coil embolizations now. And what we know is as soon as these coils come in contact with your varices thrombose immediately. And you can do 1, 2, 3, or even 4 coils if you want to. And the safety and technical success is quite high, meaning it's very efficient in inducing thrombosis with a very low adverse events. And I'll show you some interesting studies that we led in this concept. These are the 2 coils that are available. Again, these are what our colleagues in interventional radiology use. So if they're using embolization for a bleeding vessel, they're going to use these kind of coils. So Nestor embolization coils and Tornado embolization coils. The important thing is to know what size you have, and I'll tell you my technique in a second, and know the length of them. So you have small coils, you have long coils, you have thick coils. So they come in various shapes and sizes, and that's good to know when you're dealing with multiple different varices. I want to show you very quickly here, if we can play the first video about how the coils come out. Can we play the first video, please? So the coil is preloaded to the needle. You're advancing the stylet, and you guys can see here that coil coming out, and that's exactly what it's doing inside the varix. And that's how it looks at the end. And so it's inducing this thrombosis by filling the gastric varix. The picture on the right here that I'm going to play is how it looks in reality when we're doing this. It's a little bit scary. Can we play the second video, please? So here you can see the needle coming at 1 o'clock next to your varices, and you're going to puncture, and your coil's already at the end of your needle tip. So now you're advancing your stylet, and your coil is going to start filling. You guys can see the coil there starting to fill your gastric varix quite nicely. And when you use Doppler, you'll find that the Doppler flow goes immediately, if not diminishes significantly. And so here the coil is filling, it's filling, and then you'll slowly start to pull back your needle once you're happy with where the coil has filled. And that's how you complete an EUS-guided coiling of a gastric varix. And this is a very nice example here where you could barely see the varices anymore. So how do I do it? What's my technique? So my patients are intubated. They're in the left lateral decubitus position. They're always given antibiotics. You are sticking through the stomach into a vessel, so there's a risk of translocating. I always start with an endoscopy to look for the gastric varices. And if the gastric varices are small and you're worried you won't see them, put a clip near them. That way you'll know where to go. I use a linear echo endoscope. It's obviously the therapeutic endoscope that you need. And one key trick that I've learned from my mentors is put a lot of water in the fundus of the stomach. And that's because it'll make it much easier to see. The picture on the top is about 200 milliliters or cc's of fluid filling the gastric fundus. And you can see how pretty the gastric rugae are. So you can see those varices very, very nicely. I use a 19-gauge needle for very big varices where I can put an 0.35 coil or a 22-gauge FNA needle if I'm doing a smaller injection or a smaller coil. I'll try to target the varix, but if I can see the vessel that's feeding the varix, I'll also go in there. I always allow for Doppler flow to guide. If you put a one coil in and you do Doppler and that's it, you don't see any flow, you're done. You don't have to put any more. If you still see some flow, you could stop. The other thing I do is instead of chasing it with cyanoacrylate, we started to use gel foam or absorbable gelatin sponge, which I'll explain in a second. But you can chase it with some absorbable gelatin sponge, but just be very careful. Sometimes inject some contrast into the gastric varix, because if you see a very big shunt that's still there, maybe it's not the best idea to inject some glue because of the risk of systemic embolization. Lastly, that I like to tell all my colleagues is if you bring these patients back again, sometimes you'll see the coil coming out of the stomach, and that's normal. That's a good sign that the varix is almost going away and your coil is starting to come out. So don't be worried about seeing that. This is an example of the perforator vein. So you can target the varix or that vessel under it that's feeding that varix. And there's some good data that targeting the perforator may help in the number of sessions that you do. So you don't have to bring the patient so many times to do this. And the adverse events rate is quite similar. This is what we're using in the United States now. This is what IR uses when they're using their BRTOs and coil-assisted venous obliteration. So this is available for our surgeons, so we're allowed to use it. It's used for vascular access and vascular hemostasis. It comes in either a gel or it comes in a sponge, and you make the gel at bedside, which is quite easy. This is, oops, sorry. Can we play the video, please? This is just a very quick example of a publication we had where we prepared it. That's the gel foam there. You cut it into very small pieces to make your slurry. Once the pieces are quite small and you're happy with them, you're going to cut them even smaller. And that's so you can pack it into your syringe. So this is your syringe here. You're going to close it, and then you're going to attach it to a 3-way stopcock with some saline and some contrast. And now you're just going to mix until you make your cocktail ready for injection. And now your slurry is there in case you need to use it, which is easy to use and safe to use. The risk of embolization is very low, and gel foam actually dissipates out of your body quite quickly within a few weeks. So you don't have to worry about the risk of embolization. So how good is EUS coil therapy versus direct injection? We did a study to compare in a matched cohort study. And the technical success, like I said, is very similar. The adverse events were a little bit higher with cyanoacrylate injection, but this was not statistically significant. But look at your reintervention rate at 9 months. The patients who had EUS coiling had much less need for reintervention versus the patients who needed cyanoacrylate. And when you look at your Kaplan-Meier curves, you could see significantly how nicer the curves are. The time to rebleed is much less when you coil. The time to give more blood is much less as well. And so this is some early data into comparing direct endoscopic injection versus coiling. We then looked at a meta-analysis to compare all of the modalities of EUS available. And what we found is that if you coil and you use cyanoacrylate, or you coil and you use glue together, that's the most superior way of treating gastric varices. So it's more superior than coiling alone, and it's more superior than cyanoacrylate alone. So if you can do both, by all means, you should try to do both. All of this work led to this recent publication that we had. This was just published in GIE, this issue, for anybody receiving the GIE edition. This was the first US multi-center experience that we led, 10 centers in the US, and we just wanted to see how good we are in coiling. So this was US-guided coil therapy. It was a retrospective study. We had 106 patients who underwent EUS coiling. This is one of the biggest cohorts to date. The technical success, meaning successfully deploying a coil, was 100%, and your clinical success, meaning no evidence of bleeding at 1 month, was about 88%, which is quite good looking at how gastric variceal bleed. We did have about 2% intraprocedural complication, and most of those complications were non-significant, and about 5% post-procedural complication. Recurrent bleeding did happen at 14%, so at 15 patients at about 1 month, and many of those patients that had bleeds again came back and had more coils placed. So we didn't even have to send them to IR, which is very reassuring. And the best thing that we noticed about the study is if you're a low volume center where you're not doing a lot of EUS coiling, you still had very good outcomes. Centers that did less than 5 had good outcomes, similar to centers that did more than 15. So the learning curve isn't very steep, which is really good news for those interested in doing it. Our colleagues in India came out with an article at the same year, which was a multi-center study looking at coiling versus endoscopic injection. So that's 2 papers within 1 year on coiling, which made us very excited. And their center was for between India and Italy. It was 4 centers. They had 276 patients. And they compared them to direct cyanoacrylate injection. And as you guys can see here, if you use coiling, you needed less sessions for these patients to come back to. You had lower subsequent bleeding, and you had lower intervention rate. But they did notice that if you have big gastric varices that are about 2 centimeters or more, the chances of reintervention is quite high. And that's because these varices want to bleed. The risk of bleeding is much higher. For those of you who were at the liver meeting, or AASLD, we had a paper here that was a multi-center study. Dr. Ayman al-Muhadib was kind enough to be a part of it, and many of you may have completed this survey for us. But we wanted to see what are practice patterns across the world. What are people doing? And what we noticed is that people in the US are coiling, but nowhere else. People in Far East Asia, in the Middle East, are still doing direct cyanoacrylate injection. We also noticed that healthcare physicians in the US send to IR a lot, while our colleagues in other parts of the country aren't. So clearly there's so much variation in managing gastric varices, and we still need a lot of work to get to better guidelines and ways to treat this. Most guidelines don't have mention of EUS coiling, but we're starting to see a glimpse of it. Bovino, which many of you know is a big society, had recently slowly introduced EUS coiling into their algorithm management, which is finally exciting for us. They're finally recognizing it as a potential therapy. It's low down and below where you guys see secondary intervention, but there is a role for it for primary bleeding as well. So finally seeing some glimpse of it. And just to finish off here, what about putting coils for primary prophylaxis, so patients haven't bled yet? Well, this is an option. This was a big center that was done, and they noticed that it's very successful. It does reduce the rate of potential bleeds in the future. But we still need more data about this. Putting a gastric coil into a patient that hasn't bled yet may still be a little scary, and I still think we need some more information. So what's lacking? What do we need for the future? We need to understand more how gastric variceals bleed. We need to understand when to coil, when to glue. We need better tools. We're still using tools from IR. I'm talking to some companies to maybe make an EUS needle that has preloaded coils, which would be very nice to do. And then we need better uptake from our colleagues in general GI and particularly hepatology, that EUS coiling is real and does help. So gastric varices, remember them. They are rare, but they still happen and they can have significant bleeding. Manage your GOV1s as esophageal varices. Understand that cyanoacrylate is still very good, but does have some limitations. And try to acknowledge that EUS coil therapy is slowly emerging. Reach out to your interventional endoscopists and see if they're comfortable doing it. Majority are comfortable doing it if they have all the resources. And I wanted to thank everybody very much. This is Washington University. Abdullah and Ayman may recognize this picture. It sits in front of a very nice park called Forest Park in St. Louis. And thanks again for having me.
Thank you, Ahmed, for outstanding and state-of-art lecture. So it's my pleasure to welcome our next speaker, Dr. Mohammed Al-Bishir. He's a consultant gastroenterologist and therapeutic endoscopist at King Fahad Specialist Hospital in Dammam. He's the director of endoscopy unit and the program director of gastroenterology fellowship. So Mohammed has interest focused mainly in pancreatobiliary. So Mohammed's welcome, and his talk will be about cholangioscopy, diagnostic and therapeutic advances and options.
Assalamu alaikum wa rahmatullah. Sabah al-khair. Good morning, everybody. Thank you, Nawab, for the kind introduction. First of all, I would like to congratulate the organizing committee for this outstanding meeting. So I'm going to talk about advanced diagnostic and therapeutic advances of cholangioscopy. So this is my relevant disclosure. I hope by the end of my talk, everyone in the audience will be able to list the indication for cholangioscopy, understand the diagnostic value of cholangioscopy in biliary diseases, and recognize therapeutic advances available. So I will start with a case of 55 years old lady who was referred as a case of PSC with recent history of abdominal pain, weight loss, and worsening liver function. She had an MRCP which showed a hilar stricture. There was a questionable whether this is a mass lesion or a stone. The CBD was not dilated, and there was multiple periportal and portocaval lymph nodes. So this is the fluoroscopic image. As you can see here, there is a relatively long and tight common hepatic structure. Not surprisingly, the cytology brush was negative. So the question is, what next? Biliary stricture is probably an everyday challenge for most gastroenterologists. The most important aspect in dealing with biliary stricture is to differentiate whether this is malignant or benign. Usually, biliary stricture will drive an extensive diagnostic and therapeutic workup to reach a diagnosis. This is just to tell you how the list is long for causes of biliary stricture, ranging from many benign etiology to several malignant causes. So indeterminate biliary stricture basically defined as biliary stricture without definitive diagnosis following cross-sectional imaging and ERCP with standard biliary sampling. It constitutes around 20% of biliary stricture. Most importantly, 2/3 of indeterminate biliary stricture are malignant, and interestingly enough, a quarter of patients who goes for major surgical resection for presumably malignant biliary stricture turned out to have benign stricture. So that's why it's extremely important to identify whether this is malignant or benign stricture before sending those patients to major surgery. Dominant stricture is just a subtype of indeterminate biliary stricture in the setting of PSC. It's defined as a CBD stenosis of less than 1.5 or a common hepatic duct stenosis of less than 1 millimeter. Dominant stricture is a cancer until proven otherwise. Unfortunately, the standard sampling through ERCP has a low diagnostic yield. So why the sensitivity is low in dominant stricture? This is mainly due to the nature and the pathophysiology of those strictures. They tend to grow submucosally rather than radial mucosal growth. They have an extensive desmoplastic reaction, which makes it difficult to pick up new plastic cells. And most importantly, the limited and inadequate and indirect visualization when we are trying to biopsy those lesions with the standard ERCP. This is a systematic review and meta-analysis showing that the brush cytology has a very poor sensitivity, reaching 45%. Fluoroscopic guided intraductal biopsy have the same sensitivity of only 45%. Whether combining the two will increase the sensitivity marginally to less than 60%, which is still below the optimal level. So that's why we need direct visualization of the biliary tree. This is cholangioscopy. Cholangioscopy is simply a direct visualization of the biliary tree. The first optical colonoscope was described in 1941. Subsequently, perioral approach has been introduced in the early 70s. This is probably was thankfully before my era. This is a mother-daughter cholangioscope. It's a two-operator system. It needs two endoscopists. The mother scope is very fragile, easily broken. This is a very cumbersome procedure, time-consuming, labor-intensive, and I'm happy that I haven't had to do it. Perioral direct cholangioscopy is simply using an ultra-thin endoscope. The disadvantage of that is that you have to start with an ERCP, you have to load the bile duct with the guide wire, and then you have to exchange the duodenoscope with an ultra-thin endoscope over the guide wire. The challenge is to reach the ampulla, you will encounter a significant loop in the gastric stomach, so it's very difficult to reach the ampulla, and once you reach the ampulla, and go and you enter the bile duct, it's extremely difficult to stabilize the scope inside the bile duct, and sometimes you need a balloon catheter to anchor your scope in the bile duct. So thankfully now we have the digital cholangioscope or a single operator cholangioscope. This is a single operator, it's single used. The endoscope and the catheter can be passed through the working channel of the duodenoscope during ERCP. It has a 4-way steerable catheter tip, which maximize manipulation, improve assessment and visualization. The new generation of cholangioscope has a high definition imaging, which improve visualization. So basically, digital cholangioscope have revolutionized the way we approach biliary diseases. This does not include only diagnostic, but it does have therapeutic utilities. You can see here we have a laser lithotripsy catheter, followed by an EHL laser lithotripsy. We can pass a biopsy forceps, we can pass a snare, we can pass a basket as well. So this is one of the largest multinational prospective real-life data led by our dear colleague, Professor Majid Al-Madi, looking at the utility of single-operator cholangioscopy for the determination of indeterminate biliary stricture. As you can see here, they looked at whether the perioral cholangioscopy visualization only, as well as the histopathological evaluation. And as you can see here, the sensitivity of just by visualizing the lesion can reach up to 86%, and with a histopathological examination can reach to 75%. Using a histopathological examination, you can maximize and improve your specificity and positive predictive value to 100% with an overall accuracy of 85%. This is just a single prospective randomized multi-center trial comparing standard ERCP brushing with cholangioscopy. As you can see, cholangioscopy directed biopsy outperformed ERCP brushing. We can also maximize and improve diagnostic accuracy as well as sensitivity by utilizing ROSE, rapid on-site evaluation with touch imprint cytology, as seen in this small cross-sectional study, which showed that the overall sensitivity can improve by utilizing ROSE with touch imprint cytology to reaching 100% sensitivity and a diagnostic accuracy of 93%. This is a systematic review and meta-analysis of diagnostic performance of both peroral cholangioscopy as well as digital cholangioscopy. It includes 13 studies, mainly randomized control and prospective study, more than 800 patients. The overall pool sensitivity and specificity were 88 and 95%. This is a group of 12 expert biliary endoscopists have looked at whether they can create a model to optimize the diagnostic performance of peroral cholangioscopy just by visualization. And they have created an 8 visual criteria or 8 visual features. They call it Monaco criteria or Monaco classification. The inter-observer agreement was fair in this, and the overall accuracy by utilizing these 8 visual features can reach up to 70%. Artificial intelligence, as in every field in endoscopy, does have a role, and it will have a role in the future, as shown in this small pilot study. This model of AI was promising in identifying malignant biliary strictures. So back to the case, can you please? So we started with a cholangioscopy and we advanced it. You can see here, there is a mass-like lesion, there is a stricture, and there is papillary projection. So all features are highly suggestive of neoplasia. Just for the sake of the time, can you advance the video to 54 seconds, please? You can just advance it to 54 seconds. Okay. Just for the sake of the time, we proceeded with an intraductal biopsy, but I'm not going to show it here. So, and the end result was moderately differentiated invasive adenocarcinoma, and then patient can have appropriate therapy. So just remember, cholangioscopy should be implemented in any practical approach for managing patients with indeterminate biliary stricture. So another clinical application of cholangioscopy is probably delineating and assessment tumors preoperatively. This is a multi-center prospective cohort of more than 100 patients. Looked at whether doing a preoperative cholangioscopy in a patient with pancreaticobiliary neoplasia can alter the surgical plan. So the initial therapeutic plan was altered in 34 patients. More extensive surgery was required in 10%, and less extensive surgery was required in 65%, and surgery was avoided in the remaining 25%. The overall correlation between surgically resected specimen and cholangioscopy-directed biopsy was 88%, which is high. So moving to another indication of cholangioscopy, this is a snapshot of a fluoroscopic image. I'm sure if you see this, you will probably understand that it will be extremely difficult to clear the duct using conventional ERCP tools. What makes a stone is complex and difficult to extract is there are multiple factors, mainly stone-related factors and bile duct-related factors. The stone-related factors mainly related to the size, to the shape, and whether it's impacted or not, whether there is a single or multiple stones, and whether it's intrahepatic or extrahepatic. Bile duct-related factor is usually related to the anatomy and the angulation of the bile duct. There are other factors that can predict failure of ERCP and stones extraction, like post-surgical alternatomy, low endoscopic experience, as well as inadequate setting. So we proceeded with, can you turn the video on, please? So we proceeded with the cholangioscopy, and you can see here there are multiple stones, large-shaped, difficult to crush. It took actually longer time to clear this duct with laser lithotripsy. However, the end result was very appealing, as you can see here in the left image, with an occlusion cladiogram negative and cleared, indicating clearance of the duct. So not every small duct is simple, and not every large duct is complex. So you can have a very single small stone that is extremely difficult to extract using conventional tools. As you can see here in the left side, this is a cholangioscopic image of a stone that is impacted in the wall. It was extremely difficult to pass proximal to the stone with a basket or a balloon. So we proceeded with the cholangioscopy. Can you turn on the video, please? Again, for the sake of the time, the stone was cleared and the bile duct is cleared. It took only a few minutes to clear this single small stone. There are multiple randomized control trials comparing cholangioscopy-directed lithotripsy with conventional tools. The results are inconclusive and inconsistent. This is probably related to significant heterogeneity between all studies. There was lack of standardized definition of complex stone and the different techniques used, as well as the small sample size in most of the studies. So moving on to another case of 40-year-old female with large complex CBD stone. She had previous cholecystectomy 5 years back, multiple unsuccessful ERCP for stone extraction. You can see here a large oval stones in the mid-CBD. I just want to draw your attention to something radio-oblique in the common bile duct. We're going to see it soon here. Can you turn on the video, please? I hope we can advance them. So we crushed this stone using laser lithotripsy. I have to advance it here to 1.23, please. Yeah, great. So just go to 1 minute and 23 seconds. Perfect. So we crushed the stone, and then you can see here multiple metal-like structures in the middle of the stone. You can see that the rest of the stone proximal to the clips, this is a surgical clips, by the way, that's still there. So probably the surgical clip was acting as a nidus for stone formation, and that's what makes it extremely difficult to extract and crush the stone with conventional methods. So we proceeded with cholangioscopy-guided foreign body removal using biopsy forceps. Can you turn on the video? You can see here the biopsy forceps, and you can see here the clips. We're trying to directly visualize the clip and grab it with the biopsy forceps. The end result, we retrieved around 6 clips from the ampulla, as you can see it here, and the end result was clearance of the bile duct. Another clinical application of cholangioscopy is Mersey syndrome. It's constituted around 1.4% of patients with gallstone. This is usually treated surgically in the past. That's the fact that conventional ERCP is successful in only 40% of patients. However, large series have shown that the success of cholangioscopic-guided intraductal approach can reach up to 91%. We should limit cholangioscopy-guided therapy to only type 2 and type 3 Mersey syndrome. So this is a case of Mersey syndrome, ERCP done. I failed to extract the stone with conventional methods. I suspected Mersey syndrome. MRCP confirmed Mersey syndrome. Actually, initially, the patient was surprisingly referred for hepatobiliary surgeon for CBD exploration. However, we saved this patient from a major CBD exploration by doing cholangioscopy and laser lithotripsy. So just remember, cholangioscopy should be integrated in the flowchart on the management of biliary stones. If you have a high predictor of failure to clear the bile duct, please proceed with cholangioscopy sooner than later. Moving on to another case of 30-year-old lady who is otherwise healthy. She had post-cholecystectomy complicated, unfortunately, by CBD injury and bile leak. ERCP confirmed bile leak, as you can see here. I tried to cannulate the bile duct and advance the wire. It kept coiling. It couldn't pass through the area where there is a filling defect at the surgical clip site. Despite several attempts, despite using different wires, I was unable to pass the wire in. So we proceeded with cholangioscopy. Can you turn the video on? So as you can see here, the surgical clip is in the bile duct, causing the stricture and the injury. So we manipulated through this clip with the cholangioscope and the wire, and eventually I was successful to pass the wire through, as you can see here. So this is the cholangioscope, and the wire passed beyond the area of injury, subsequent balloon dilatation to insert a biliary stent to manage this patient leak. So moving on to another case of post-liver transplant and stomach stricture. This is a 15-year-old girl with Wilson disease, has underwent liver transplant in 2019, duct-to-duct adenosynostosis. Our colleagues from transplant hepatologists referred it to us because of worsening recurrent abdominal pain and elevated liver functions, and later she developed jaundice. Liver biopsy showed no acute cellular rejection. MRCP confirmed a significant and tight anastomotic stricture with upstream dilatation, as you can see here. I did an ERCP. Despite several attempts, I couldn't pass this tight anastomotic stricture. We proceeded with cholangioscopy. You can see here there is like a blind end. There is a complete obstruction, but if you can notice, there is a very small pinpoint orifice or hole. So that's why it was extremely difficult to cannulate this structure blindly, as the wire preferentially goes into different directions. But utilizing utilizing a cholangioscope, directed wire cannulation, I engaged the wire into this orifice, and you will see it soon here. So once it's engaged, see how it's difficult? That's despite seeing it directly. I tried to engage the wire into this pinpoint orifice. Now, you can see it now. So once I engaged, I suctioned and I extensively irrigate, and eventually I was able to pass this tight anastomotic stricture with extreme difficulty, and you will see it in the upright picture fluoroscopic image. So this is pre and post wire cannulation. You can see the differences. This patient underwent several serial endoscopic management and dilatation, and eventually we saved her a redo transplant. Moving on to surgically altered anatomy, 70-year-old male, total gastrectomy for gastric cancer, esophagojejunostomy, presented with acute cholangitis secondary to CBD stone. So what's next? We asked our colleagues from interventional radiology to do a PTD. As you can see here in the right image, you can see a stone in the proximal bile duct. And then we proceeded with a percutaneous approach, percutaneous cholangioscopy, utilizing a dedicated percutaneous cholangioscope. So our IR colleagues have inserted an 11 French catheter for us. We put a wire through it, and we advanced the cholangioscopy percutaneously through the sheets over the wire, and we proceeded with an antegrade management of stone. Can you press the video, please? So this is a stone seen in the common bile duct. This is an antegrade approach. We proceeded with the lithotripsy, and subsequently, you can see here the stone has been fragmented in the common bile duct. You can see small, tiny filling defect now in the distal duct. We proceeded with a balloon sweep in an antegrade fashion. We pushed the residual stone transpapillary into the duodenum, and then we have a clearance of the common bile duct. So cholangioscopy is not free of adverse event. As shown in this large retrospective study, the main drive of adverse event in cholangioscopy is cholangitis in comparison to ERCP alone. There is no statistically significant difference with regard to risk of pancreatitis or perforation when you compare cholangioscopy to ERCP. Thankfully, we can minimize the risk of post-ERCP post-cholangioscopy cholangitis by administering preoperative antibiotic. So in summary, clinical application of cholangioscopy is not only in the management of difficult bile stone and not only in the biliary structure tissue acquisition for biliary structure, but there is a role for it in the intraductal delineation and staging of tumor, tumor ablation, foreign body removal, as well as manipulating difficult and negotiating difficult structure with selective cannulation. So my take-home message is that the two main indications for cholangioscopy is diagnosis of indeterminate biliary structure, treatment of complex stone. Cholangioscopy-guided intraductal intervention appears to expand the role of endoscopic treatment beyond those two main indications. The availability of cholangioscopic assessment and intraductal guided diagnostic and therapeutic intervention can be considered during the index ERCP and may reduce the need to perform multiple ERCP procedures. Thank you.
Thank you, Dr. Muhammad, for a great presentation. We'll move on to the fourth and last presentation of this advanced endoscopy session this morning. It is my pleasure to introduce Dr. Faisal Al-Shatti. He is a consultant gastroenterologist at Al-Ahmadi Hospital in Kuwait. He did his internal medicine training at King Faisal Specialist Hospital in Riyadh. Then he did his GI fellowship training at the University of British Columbia, Canada, and this is where we first met. Then he did US fellowship at London, Ontario. Dr. Faisal will be speaking about approach to subepithelial lesions.
Assalamu alaikum. Good morning, everybody. It's a pleasure to be talking amongst this elegant audience. And I'd like to thank SGA for inviting us and arranging this wonderful meeting and gathering. So it will be a much lighter talk, basically explaining the approach to subepithelial lesions, which we encounter a lot during our day-to-day endoscopy and practice. So the talk is based on these two guidelines from ESGE in 2022 and from ACG in 2023. We'll start off with a definition. So subepithelial lesions are a mass or a mass-like structure that typically project into the GI lumen and arise from a non-mucosal layer within the GI tract wall. As you all know, the GI tract wall has 5 layers: the mucosa, muscularis mucosa, submucosa, musculus pavia, and then serosa. They are very evident and clear on EUS. They are alternating white and black lines. The black resembles the muscle layers. Hopefully, by the end of this talk, we'll be able to differentiate all of these types of subepithelial lesions and know how to treat them. So we'll start off with clinical presentation. Most of the time, they are asymptomatic. They are detected incidentally on endoscopy that we do for other reasons, or on imaging like CT or MRI. However, in a minority of cases, they can actually present with symptoms such as GI bleed or iron deficiency anemia. Sometimes they can present with dysphagia, especially if they're in the esophagus, and other times they can present with obstructions if they are in the small bowel tract. They can be benign, pre-malignant, or malignant. The objective by the end of this talk really is to identify and characterize these lesions, and we will emphasize on the role of EUS and when to need tissue acquisition. And then we'll shift gears to management, whether to do any surveillance, no surveillance, or resection, and if we decide on resection, how to do it. We all know the two types of echoendoscopes, the radial echoendoscope and the linear echoendoscope, and the advantages and the disadvantages of them. Personally, I usually prefer to start with a radial echoendoscope when examining subepithelial lesions, and then proceed with linear echoendoscope if I need further characterization or I need tissue acquisition. The advantages of EUS are well known. You know the size, the location, the originating layer, any high-risk features, and so on. And now we have additional advanced modalities such as elastography, contrast enhancement, and Doppler. And sometimes, despite all of this, we are still unable to know the type of subepithelial lesion. And in that case, we proceed for tissue acquisition, which is also feasible by EUS. This is just an example of elastography. The blue is really hard and stiff, resembles malignant or pre-malignant conditions or muscle, and the green is benign. The contrast enhancement, the more contrast you have, the more hypervascularity, and the more this is more of a malignant condition. So basically, you have to achieve the characteristic radiographic, endoscopic, and endosonographic appearances in addition to judicious use of EUS-guided sampling in order to achieve a definitive diagnosis in most cases of these lesions. And why it is important to diagnose? It's important because this will implicate the subsequent management, whether just to observe the patient, whether to do active surveillance or to resection. However, in a minority of patients, we really do not need to have the diagnosis. And the cases are if we have significant clinical symptoms or bleeding, then we proceed to resection as a management plan. So first of all, we have to differentiate, is this lesion extramural or intramural? And the extrinsic structures, as you know from your anatomy, could be gallbladder, could be spine, could be bronchogenic cyst, and so on. Endoscopy is not that specific. It's only up to 30% specific. However, EUS improves that to nearly 100. So if you can see here, we have two examples. There's a lesion in the antrum that we're not sure of, and EUS shows this clearly as a gallbladder. And then on retroflexion, in the second picture also, we are not sure what this bulge is, and it appears to be clearly as the left lobe of the liver. We'll proceed now into the different types of subepithelial lesions, starting with lipomas, which are probably the only solid lesions that we sometimes don't need EUS to diagnose. They have typical endoscopic features, such as the yellowish hue and the positive pillow sign, and they have also radiographic features. So they have significant house field units on CT resembling the fat in the body. And probably with these lesions, most of the time we don't need EUS or sampling. This is an example of a lipoma in the antrum again. You see it hyperechogenic on the EUS image, and upon deroofing, you can see the fat tissue coming out. We move on to the next type, which is also benign, duplication cysts. Duplication cysts can originate from the third layer, which is the submucosa, or they can be external. They are anechoic, okay, and they have a negative Doppler sign. These are, again, benign lesions that we frequently encounter. We move on to ectopic pancreas, which we also see very frequently in our day-to-day endoscopy. It originates usually from third layer. They are hypoechoic. They can resemble the actual pancreas tissue because, remember, they are actually pancreas. So you see the typical salt and pepper appearance. You can see cysts, you can see ducts, and so on. And endoscopically, they typically have the central umbilication. They are usually small, less than 20 millimeters, and most of the time they are in the antrum. They are also benign lesions. Now we move on to a more malignant or a pre-malignant condition, the neuroendocrine neoplasia. And these usually need talks and talks really to further emphasize on. They originate from the second or the third layer. They can invade into the mucosa, and sometimes mucosal biopsies are sufficient to diagnose them. Endoscopically, they are rounded. They have a different color than the surrounding mucosa. They can be multifocal, and they have variable echogenicity, variable location, and variable behavior, and the management depends on that. For example, in the gastric alone, they have 3 types. So type 1 is associated with atrophic gastritis and pernicious anemia. They are small, less than 1 centimeter, and they are multiple. Type 2 is associated with Zollinger-Ellison syndrome with MEN type 1. Type 3 is more aggressive. They can present with METs upon presentation, and they are sporadic, but the typical thing is that they have a normal fasting serum gastrin. This is just a summary of the 3 types. We move on to the muscle or the muscular submucosal subepithelial lesions. Leiomyomas, they are very important because these are the ones you need to differentiate from GIST. They originate from the muscle layer, either the second or the fourth. They are hypoechoic, and homogeneous is the really key word here in differentiating them from GIST. They can be located anywhere in the GI tract, but they are most common in the esophagus or in the stomach. We move on to GIST, which is really the nutshell here. They originate from the same layers, the second and fourth, the muscle layers. They are hypoechoic, but most of the time they are heterogeneous. And you have to really specify on the morphology there because different morphological features indicate high-risk signs, such as hypervascularity, cystic spaces, echogenic foci, and of course the size. More than 3 centimeters is more typical of a high-risk GIST. They can happen, again, anywhere in the GI tract. So this is just in a nutshell about the high-risk features with GISTs on EUS. We move on to granular cell tumor. These have a slight potential of pre-malignancy as well, and this is why they're important. Mostly they are in the esophagus. They originate from the second or third layer. they are hypoechoic, but a little bit higher echogenicity than the muscle layer, and they are heterogeneous. Usually, they are small. Glomus tumors are benign ones. They originate from the third and fourth layer. The typical thing with them on morphology is that they are hypervascular with internal echoes. This is just a summary of the different types, their location in the wall layers, the typical sites, and the malignancy potential. We move on to tissue acquisition. Now we finish with the morphology. We'll talk about sampling. First question is, why to sample? So we sample because the diagnostic accuracy, sensitivity, and specificity are quite low with morphology alone. And we need really to have a diagnosis to differentiate benign from malignant. The other thing is that there is an inter-observer variability, as with all ultrasounds. And two physicians can, or two endoscopyographers cannot sometimes differentiate between leiomyoma and GIST based on EOS features alone. And the addition of tissue acquisition can increase the accuracy from around 50% to nearly 80%. The other question is when to sample. Usually we sample asymptomatic hypoechoic tumors, which are more than 2 centimeters, if we are considering surveillance. And this is very true in esophageal subepithelial lesions and gastric hypoechoic lesions. Again, it's just to differentiate the benign from the pre-malignant from the malignant. Another indication is large tumors that we think they are GIST and they need imatinib. The third indication is if you have an atypical appearance and you have a suspicion whether this could be cancer, lymphoma, or METs. When not to sample, we don't sample if the symptoms make resection necessary because you're doing an unnecessary procedure, you're doing resection anyways, or if the EOS features are really typical of lipoma and duplication cyst, and these are benign, they don't need any more further surveillance, or if the patient is not candidate for treatment anyway, so why bother with an unnecessary investigation? And most of the time, we don't sample small lesions that are less than 2 centimeters, that are hypoechoic, that have no worrisome features. These could be really followed up safely because of their low risk of malignancy. Other question is how to sample. Should we do EOS? Should we do the jumbo unroofing? The jumbo unroofing means that we use a jumbo biopsy forceps to remove the mucosal layer and then repeated biopsies inside to attempt to get the subepithelial tissue. However, we don't recommend that unless you don't have EOS. And you have to, before you do that, you have to make sure that this is not a vascular lesion based on clinical scenario and EOS appearance. FNB biopsy versus aspirate. There was a meta-analysis of around 700 patients comparing both. FNB was better in the adequate samples, histological codes, diagnostic accuracy, and fewer numbers of needle passes. However, if you have rows in addition to FNA, then probably they are equal. Now we'll switch gears to the next section, which is management. Again, we'll speak when to not surveil, when to do surveillance, and when to do endoscopic resection. So no surveillance basically is if we have benign lesion and we have a clear diagnosis that this is a benign lesion, such as leiomyomas, lipomas, heterotopic pancreas, most of the granular cell tumors, schwannomas, and so on. This is because the risk of malignancy is really negligible, and there is no evidence that surveillance will provide any benefit in those patients, unless they're symptomatic, of course, unless they're causing obstruction, dysphagia, anemia, and so on, then you proceed for resection. What do we mean by resection? The goal of resection is to achieve an R0 resection with negative margins, low morbidity rate, and plus that these tumors should not have invaded any regional lymph nodes. Indication for resection is if there's a risk of malignancy, as in GIST and neuroendocrine neoplasia, and infrequently with granular cell tumors, as we have known now, or if there are symptoms such as obstruction or bleeding, or now a new emerging indication is bariatric surgery, where lesions are found specifically in the locations near the GE junction. The techniques, there are merely 4 techniques. EMR, which we all know, you inject, you elevate, and then you resect. You can do the band EMR, you can do the underwater EMR, ESD, STAIR, which is submucosal tunneling, similar to POEM, and then the full thickness resection, which has a device like an Ovesco. You clip the whole wall, and then you resect without causing a perforation. This is just a quick cartoon about the different types. We'll speak specifically about the SELs in the esophagus, the 2 types, the granular cell tumors, We don't remove them unless they're causing dysphagia or increasing in size. This means they are getting more in a malignancy position. And the best technique to remove them is with EMR band ligation, especially if they are small and limited to the submucosa. The other lesion in the esophagus is the fourth layer lesions that are the dilemma here, whether it's a leiomyoma or a GIST. And they have been testing what the best technique, whether it is STIR versus thoracoscopic inoculation. There was a study with 166 patients, large size, although the tumor size in the STIR group was slightly smaller. They were about the same, so the success rate of en bloc resection was similar. However, the mean time for STIR and the hospital length of hospitalization was significantly shorter with STIR, and the incidence of adverse events was similar. So basically, both are feasible depending on the experience you have in your center, whether to proceed with one or the other. We move on to management of GIST. This is usually controversial, needs an MDT meeting, but basically, if it's a small GIST, it has a low malignancy risk, so you proceed for surveillance. And the surveillance starts in a shorter period, 3 to 6 months, and then extends annually every 2 years, every 3 years, depending on the size of the lesion. However, if it's more than 2 centimeters, then the rate of metastatic spread is increasing. And it can reach as high as 86% for lesions that are greater than 10 centimeters. Thus, you proceed with resection plus or minus neoadjuvant therapy, and this is where the MDT team really helps. If it's extragastric, then you proceed with resection independent of the size. They have been examining 3 approaches, whether to do ESD, whether to do laparoscopic resection, or a combination of endoscopic and laparoscopy. They found that ESD is better for smaller GIST sizes, 2.8 or so, because the operative time and the blood loss were less. However, in general, both 3 approaches have been found to be effective and safe with the same adverse events and the tumor recurrence rates. We move on to the next entity of malignant subepithelial lesions, neuroendocrine neoplasms. And in these, probably you have to go for resection instead of surveillance most of the time. Type 1 GNS, which we spoke about, which are associated with pernicious anemia, as well as atrophic gastritis. The best technique to remove them really was ESD, because you have more of a negative margin resection and more of a vertical margin involvement as well. Now, for rectal ones, this is a very common scenario that we encounter as general endoscopists. You do your colonoscopy for screening or whatever, you found this polyp in the rectum, you remove it with cold snare or whatever. However, the pathology comes back as neuroendocrine tumor with positive margin. So what do you do in this case? The advice really is to repeat the endoscopy at 3 to 6 months, and then if there is remnant tissue, you have to remove it with ESD or band EMR. However, if there is no residual recurrence, then you biopsy the scar itself to rule out microscopic disease, and if this is ruled out, then you are safe. This is because rectal neuroendocrine tumors, they have a high risk of mets depending on the size, and with these, as we said, ESD would be better to achieve R0 resection. This is just, I'm not sure this is not clear, but this is summary from the ACG about the approach for the lesions. And by this, I end my talk. Thank you very much.
Thank you very much, Dr. Faisal. We will open the floor now for questions. I'll start with this question for Dr. Abdullah. So, as you mentioned in your presentation that MRCP and EOS, they have comparable diagnostic quality, and most of us, actually the vast majority, we don't do EOS. So the question now, when should we refer patient with pancreatic cyst for EOS further assessment and perhaps cyst fluid analysis?
Thank you for the question. So patients who have pancreatic cysts on MRI or CT scan, and then who have worrisome features, depending on which guidelines you follow, the AGI is more restrictive in that regard. You have to have 2 high-risk features on the cyst on the imaging for you to go into EUS and do a cyst fluid analysis, while most of the other societies would argue against that and just encourage anyone with high-risk features to go through EUS with FNA and further evaluation. Usually, if you have a larger cyst, more than 1 to 2 centimeters, then it's probably a good idea to stick a needle and try to take some fluid and send it for analysis. If it's small, less than 1 centimeter, 15 millimeters, then it's probably not advisable to stick a needle and just follow it with imaging.
For Ahmed, no doubt, and a US guided vascular intervention, very exciting and growing, evolving fast actually. So, we hope one day we will IBS or TIPS the patient safely. But regarding the gastric pharynx, even it's the US proven the technical ease and the effectiveness. But if you look for the data, there is still, still a lot of open question not answered. So maybe you answer this in your systemic review, the monotherapy or dual therapy, ablation. But what you usually preferred, either to inject the perforator or the pharynx? What surveillance you are using, post the treatment? And also, if you look at the data, the agent was used as either cyanoacryl or histoacryl or gel form. There is a lot of heterogeneity in the data. So what's your advice regarding this?
Thank you very much for the question. So for the first part is, what my technique is. I think the perforator is a vessel that I get anxious about. If I feel that it's large enough and my risk of embolization is high, or I'm using a co-injectate, then I'll often just target the varix. But if I bring the patient back and I feel this has recurred, then sometimes I'll target the perforator. But my approach is the gastric varix itself, just because I don't want to see any complications, especially early on as we're developing this technique. The surveillance question is a great question. Again, there's a lot of heterogeneity. There's no standardized way. We used to bring them back after a month, then 3 months, then 6 months, and then a year, and then we have our hepatologists continue. This was just our conservative approach. I think we need better standardized ways to understand when to bring these patients back. The last thing is about cyanoacrylate. I agree. I think there's so much heterogeneity with what everybody does. I think we don't have much access to cyanoacrylate in the US. This is why we don't really use it as much. But I also know that EUS, adopting EUS coiling elsewhere is also very, very difficult. So I think what we probably need is a consensus guideline, a big group of people, leaders in the field, to sit together with hepatologists to really start to standardize this and hopefully incorporate it into better guidelines, especially AASLD and ESOLD. I think we're long away from that, unfortunately, but hopefully in the next few years.
The question for Dr. Al-Bishir. So Dr. Bishir, direct cholangioscopy represents a significant advance in the biliary disease assessment and management. The issue is that cost is an issue. And you're seeing now different companies producing different cholangioscope, and we hope this will result in cost reduction. But at the current time, how to best select patient for cholangioscopy assessment? Which patient are the best to go for either diagnostic or therapeutic purposes?
Yeah, it's an excellent question. It's always a debate about the cost. As you said, there are more newly developed cholangioscope coming in the market, so I hope that this will drive the cost down. But I can tell you that there are some few cost-effective studies have been published for cholangioscopy, and did show that you might save actually some money by minimizing recurrent procedures if you have selectively choose the right patients. So there are some predictor of failure in ERCP. So if you have, there are Orlando protocol, which I think it's reasonable. I'm not quite sure if it is validated or not. They do consider size to duct ratio, and they do consider whether the duct is tapered or not. So if the duct is not tapered, and if the stone to duct ratio is more than 1, it's probably better to proceed with cholangioscopy during the same index procedure, because the failure rate is very high. So I did show in the algorithm that if you predict that the risk of or the chance of clearing the duct is high, using mechanical lithotripsy or large papillary sphincteroplasty, I think it's probably going to be most cost effective to proceed directly with cholangioscope rather than trying to bring him again and again, putting 3 stents or 2 stents, and repeating the procedure 3 times or 4 times.
Okay, thank you. The question for Dr. Faisal. So small subepithelial lesions are not uncommon, and although they have a low malignant potential, but they're associated with patient anxiety and the need and the cost for further surveillance. So do we proceed with endoscopic resection, given the advances that we see these days with endoscopic techniques? And if we need to endoscopically resect those lesions, is EOS a must before resection?
Okay, excellent question. So first of all, as you said, we encounter lots of small subepithelial lesions on general endoscopy. I think here the size and the characteristics do matter, because very small ones it's difficult to identify on EOS. Once you put the EOS probe on them, they just disappear. You need the mini probe, which is not available widely. You need to put too much water inside in order to have it, and so on. So probably I would say that most of them will need EOS, but to a lesser extent, if they are less than 1 centimeter, it's very difficult to achieve a good diagnosis with EOS morphology alone, and it's also difficult to FNA them. So probably if they are less than 1 centimeter, then you discuss with your endosonographer whether it is needed or not, show him the endoscopic images and so on. The other thing is regarding resection. So I know sometimes it's the way you tell the patient. So if you tell them you have a tumor, then they'll of course be afraid, despite what you say, if this is benign or so on. So what we used to say in Kuwait, if it's like a leiomyoma and we're not sure, the most important thing is to be sure of the diagnosis, okay? So if it's leiomyoma, then we say this is like a, lipoma, we call it kies dihin. This one we call it kies adal, okay? And by this extent, if they understand this is just an extra muscle in this area that has no potential of malignancy, then they will be less worried. Because removing them has its own potential risk and so on. And then if you remove it and perforation happens and so on, or bleeding, or if you remove it, and then what's the next step for surveillance? So this really has to be thoroughly discussed with the patient and explained to him.
So, Mohammed, no doubt the cholangiscope add a value for diagnostic and management of intermittent biliary stricture. So, what's your usually approach for a distal indeterminate CBD stricture? So, you start ahead with cholangiscope, or you advise for EOS evaluation prior to this? So.
For distal CBD structure, I prefer to proceed with EOS-guided approach, EOS-guided FNB. For proximal structure, I go straight for cholangioscopy-guided approach.
Usually your approach, I mean, if you have a cholangiscopy biopsy has been negative, but still, I mean, you couldn't reach for a conclusion about the
I
structure.
always repeat the cholangioscopy biopsy twice, and I always try to take minimum of 8 biopsies. As some studies showed that if you take 8 and more, you are driving the sensitivity higher. So I only repeat it twice.
Dr. Faisal, what usually your preferred, I mean, tissue acquisition method in subepithelial lesions? So you are going with the FNA, either adding the rose oil to it, or you are advising for the fine needle biopsy?
I think FMB is the best now, because you get the core tissue. In cases of neuroendocrine neoplasia, you can check the Ki67 if you have good core, the mitotic index, and so on. So probably now FNA are only for cysts. For any solid lesion or subepithelial lesions, we go for FMB.
So we have 2 questions here. The first question is from Dr. Ayman Al-Mhadib.
Yeah, so maybe 2 quick questions. So one for Dr. Al-Bashir and one for Dr. Faisal. So in patients with PSC, sometimes we see let's say dominant structure. So would you advise to go brushing at the beginning and if you get the result that enough, or will you go straight to SPY to get better tissue, considering in mind, it's a small caliber of ducts and it might be really challenging to go in? So that's the first question. Second one for Dr. Faisal. Maybe if you could comment the best approach for rectal neuroendocrine tumor, because we see a lot of small rectal neuroendocrine tumor, and we all know that risk of metastasis is high in such lesions. So I would like to hear the best approach in your opinion.
Yeah, you are right. PSC, sometimes it's extremely difficult to advance the cholangioscope due to tight fibrotic distal structure sometimes. Sometimes you really need to dilate to reach the target suspected area. By I'm still in the conservative side, so I always proceed with conventional tools that I have. I try to do both cytology brush and intraductal fluoroscopy guided biopsy from the index ERCP. If those are inconclusive, which is most of the time are inconclusive, I proceed with ERC or cholangioscopy guided biopsy.
So regarding rectal neuroendocrine tumors, are always a debate. So basically, there are two things. If you know that this is a neuroendocrine tumor retrospectively, then I think the better approach is to go inside with radial EUS just to check if there are any regional lymph nodes. Or if you don't have that, the alternative could be MRI of the rectal area to check for any lymph nodes there. And then again, endoscopically, you have to ensure that there is complete resection of it. If there is no complete resection, then you have to go in with more invasive techniques such as the ESD and so on. And just remember that it's always related to size. So the bigger the neuroendocrine is, the more metastatic disease and the more care you have to take in investigating that. And of course, active surveillance for the lesion so that there's no regrowth back.
Okay, we have a question from Dr. Baha.
Thank you. For Dr. Mohammed, did you find during your experience any difference between EHL versus the laser lithotripsy machine? And the second question, I didn't notice that you touched the usage of the spyglass or the cholangioscope into the pancreas. Now, could you just enlighten us about these two?
We don't have EHL. I only have laser lithotripsy, so my experience with EHL is limited. But I had heard from my colleagues that sometimes the EHL probe doesn't really work. So I think laser lithotripsy is probably overperformed than EHL probe. The second question is for pancreatoscopy. My talk was about cholangioscopy. So if I added pancreatoscopy, I would probably gonna exceed 20 minutes for sure. So, but there is certainly a role for pancreatoscopy in pancreatic IPMN as well as pancreatic duct stone. But that's a different extended topic. Pancreatic duct stone is extremely difficult to manage. I do have some limited experience with using laser lithotripsy for pancreatic duct stones. It's not as easy as the bile duct stone, but I do see some benefit of doing pancreatoscopy for pancreatic duct stone, as well as staging and diagnosing IPMN.
Thank you.
Okay, two questions. The first for Dr. Abdullah. So patient with family history of pancreatic cancer and pancreatic cyst, what to do? Second question for Dr. Ahmed. So we see this patient with liver cirrhosis and large esophageal varices, large gastric varices that never bled. So what to do? Is treating the esophageal varices will increase the risk of progression and bleeding from the gastric varices, and how would you approach these kind of patients?
So for someone with family history of pancreatic cancer and they have pancreatic cyst, they are at higher risk of developing pancreatic cancer, so their surveillance is more strict and more regular, and they are not considered an average risk, and so the regular guidelines do not apply to them. There are a lot of data that are showing that the pancreatic cancer that arise in pancreatic cyst patients can rise from a different area than the pancreatic cyst itself. But the theory is that perhaps we have an unstable field that led to the pancreatic cyst, and somewhere else a high-grade dysplasia and then cancer developed. So I would say that those patients require more stringent surveillance method.
Thank you for the question. So, you know, if these patients have both esophageal and gastric varices and you need to co-manage both, we're oftentimes, you know, having our hepatologists lead the way, and these patients are probably better served by a decompression through TIPS or TIPS and BRTO. But the patients that aren't candidate for TIPS because HCC or right-sided heart failure, we will co-manage them. We oftentimes will not band first because you don't want to band and have to go through your bands with an EUS. So we'll go manage the gastric varix and then probably bring the patient back to co-manage their varices. It's very rare that this has happened, but it's certainly an approach that you can do.
Thank you, Ahmed. So by this, I would like to thank my colleague Majid and the SGA, and we will conclude our session, we would like to thank our superstar speakers and our audience, so we can go for a break and continue for the SDD forum.
So we'll come back at 10:55 for Takeda Satellite Symposium.
Welcome to the Satellite Symposium, industry-sponsored Satellite Symposium, the third for this conference. This is sponsored by Takeda. We'd like to thank them for their support and for their ongoing continuous contribution to the scientific activities, not only to this conference, but nationally. Our talk this morning, entitled Unveiling Paths to Achieve Remission in Inflammatory Bowel Disease. The speaker this morning is Dr. Iman Sles, who is a consultant gastroenterologist, IBD specialist, and specialist in nutrition and small bowel disorder at King Fahd Specialist Hospital in Dammam. Dr. Sles qualified in medicine from here in Jeddah, King Abdulaziz University, went on to pursue residency in internal medicine in Dammam, followed by gastroenterology fellowship at King Fahd Specialist Hospital in Dammam. Then she spent time working as a community gastroenterologist at the Royal Commission Hospital in Jubail, where she continued to contribute to literature and have a significant presence in the academic activities. She pursued a fellowship at Cambridge University, spent a year doing advanced inflammatory bowel disease and a year doing small bowel disorders and nutritional disorders, and then returned to the kingdom recently, where she joined our center. So thank you so much for attending, and Dr. Iman, the floor is yours. We have 30 minutes for this presentation.
Assalamu alaikum. Good morning, everyone. Thank you so much, Dr. Al-Amir, for this nice introduction. Thank you, Takeda, for having me today. So we'll start our talk with a case presentation. Mr. Abdullah is a 40-year-old Saudi gentleman diagnosed with ulcerative colitis 3 years back. He started initially in 5-SA, 3 grams daily, with no much improvement, and then azathioprine was started. Unfortunately, he couldn't improve the drug because of the nausea and vomiting. Since then, he has been receiving repeated courses of oral steroid, and despite that, he remains symptomatic. Almost his bowel motion at that time was 4 to 5 times per day, and it was bloody. Blood test was showing white blood cells of 4 and hemoglobin of 13, platelet of 145, CRP of 40, fecal calprotectin of 170. We did colonoscopy at that time, and it showed pancreatitis of a Mayo score of 2. I'll pause here and ask you one question. What was the biggest mistake in this case scenario? So I guess you all agree with me that exposing patients to repeated courses of steroid instead of escalating his therapy was the biggest mistake. Just to be optimistic in this lovely morning, it is also the best chance to select the right agent, as we all know that the first agent works the best for the patients. So the objective of my talk today is to talk about the steroid use in IBD patients and its impact on the patient, and then we'll talk about the strategy and the factors that we have to consider in selecting the first biologic agent in patients with IBD, and then we'll talk why and how we have to follow treat-to-target approach. Starting with the first part of the talk. So the guidelines are clear. We have to limit the use of a steroid to the induction of remission. There is no role of a steroid in maintaining remission in patients with a steroid, and also we have to aim for steroid-free remission. Unfortunately, despite that, we are still exposing our patients to unnecessary courses of steroid. You can see here that not only us as a physicians concerned about the use of a steroid, also the patients. In fact, our patients are concerned more about the use of a steroid. From our side, as a physician, we usually concerned about these kind of adverse effects of a steroid. We usually concerned about the presence of osteoporosis, diabetes mellitus, immunosuppression of the drug, cataract, psychiatric side effect like psychosis, but from the patient side effect, it is totally different scenario. This is a recent study that we did among patients with IBD. We surveyed them, and we asked about 13,000 patients with IBD. And part of the survey was about the use of a steroid and the side effect of the steroid. And guess what? 60% of the patients reported at least one side effect with the use of prednisolone. And the most bothersome side effects were mood disturbance like anxiety and depression, sleep problems, and weight gain that affect self-esteem. So at least a third of the patients were suffered from these symptoms. It is also important to mention that 5% upon the use of prednisolone were having suicidal thoughts and suicidal attempts. I hope that by this, I convinced you that we have to stand against the unnecessary use of steroid. Moving to the second part of the talk, so we'll talk about selecting biologic agent. As you can see here in this slide, that we have long lists of agents that we can use in patients with IBD. So what strategy we have to keep in mind while using and selecting these agents, especially that we know this list will be expanding more and more. I'll just share with you this slide because it showed that from the physician side of view and from the patient side of view as well, what factors we have to consider while using and selecting the first biologic agent. So I'll kindly ask you to take mental snapshot for this slide because in the upcoming few slides, we'll go and review the evidence on every single parameter of this slide. So we are in agreement with our patients that durability is the #1 factor, and then followed by tolerability, and then the speed of onset of the agent, and then the long-term safety profile, and then the route of administration. From the EVOLVE study, we know that vedolizumab has superiority when it is compared to the anti-TNF, and it showed higher persistent rate in patients with ulcerative colitis, especially in biologic-naive patients. When we compare it with the TNF, although they are effective medication, but still, we know that a third of the patient will show primary non-response. Almost half of the patient may lose the efficacy within 1 year, and 10% we may develop some side effects of the drug. Also, from the EVOLVE study, we learned that when it comes to the safety profile, it is always favors the vedolizumab. When you compare vedolizumab to anti-TNF, it is associated with less side effects. When you compare it to anti-TNF, we know that anti-TNF are effective medication, safe medication, but always there is concern of developing malignancy like lymphoma, especially when it is combined with thiopurine. Other concern is the developing of some side effect like infections. So I guess this slide was shown in this conference at least twice, but again, to emphasize, do not expose the patient to steroid. It is the horrible choice and horrible decision to go for. Instead, go to a safer option as seen in this slide. If you remember, the last concern about the patient is the route of administration. So we are lucky that since 2020, we have a lot of subcutaneous formulation of a drug, and it is not only available, but it is effective. So in VISIBLE study, we know that vedolizumab in subcutaneous formulation has superiority to placebo. And just to remind you about the study design, that patient is, this study was including patients with moderate to severe ulcerative colitis who failed conventional therapy or anti-TNF. The patients received initially IV vedolizumab and then 3 arms of the vedolizumab subcut, vedolizumab IV or placebo, and they evaluated the clinical remission at week 52. And as you can see here, the superiority of vedolizumab subcut when we compare it with the placebo with b-value of less than 0.001. Other factors, and we are lucky really to have some of the head-to-head trials in field of IBD are ongoing. And when we talk about the head-to-head trials, we have to talk about VARSITY trial, as it is the first head-to-head trial in patients with ulcerative colitis. And it showed that vedolizumab is superior to adalimumab in patients with ulcerative colitis, not only based on the clinical parameters, but also for mucosal healing. Guidelines, of course, helps in taking the decision when we come to the medication and selecting the agent. AGA recommend using infliximab or vedolizumab in patients with ulcerative colitis who is naive to biologic. Also, we know that tofacitinib is used only as a second line of treatment in patients with ulcerative colitis. And this is in concordance also with the Saudi guidelines. Saudi guidelines recommend clearly that using vedolizumab over adalimumab in patients with ulcerative colitis who is biologic naive. The same for tofacitinib, it is still second line for treatment in patients with ulcerative colitis. We have also to mention that still TNF is the best option in the following settings: in case of proctitis, penetrating Crohn's disease, perianal Crohn's disease, prevention of post-op recurrence Crohn's disease, as well as pregnancy. Other factor to consider is the presence of extraintestinal manifestation. We know that if you have a patient with IBD and spondyloarthritis, maybe the best choice to go for is either anti-TNF or JAK inhibitor. In presence of pyoderma gangrenosum, you may consider anti-TNF plus or minus JAK. In case of uveitis, the answer will be anti-TNF. In case of arthritis, and depend, of course, on the type of arthritis, is it peripheral arthritis type 1 or type 2? But the answer will be anti-TNF, JAK, ustekinumab, or maybe also vedolizumab. And in case of erythema nodosum, you may consider anti-TNF plus or minus JAK or vedolizumab. So back to the case. In case of Mr. Abdullah, we have decided to start him on vedolizumab. Just to remind you, it is not the end of the story, but it is actually the very beginning of the story. We have to have target to achieve with our patients, and we have to have also strategy to follow. And always it started with why. I guess you are all know and convinced that Crohn's disease is a progressive disease, but it is very true also in case of ulcerative colitis. We know that ulcerative colitis is a progressive disease, so a patient may develop strictures, dysplasia, colonic dysmotility, and they may end with colectomy. So that's why we have not to aim for symptomatic benefit in our patient. We have to aim higher. We have to aim for steroid-free remission, mucosal healing, and in the near future, I guess, histological remission will be also a target. And we have to aim that our patient will be functionally well and to have also good quality of life. And what impact that will affect our patients? What impact that the patient will have in this case? We know that the patients who limited their target to clinical remission will behave differently in patients we aim higher, like when we aim for endoscopic healing. We know that major outcomes will be affected. So when patients who achieved endoscopic remission will have lower rate of colectomy in comparing with patients with a clinical remission. And the strategy to follow that is STRIDE. So STRIDE gives us a landscape and strategy to achieve our targets. When it comes to short-term targets, we know that we have to target and aim to achieve a clinical response and normalization of the CRP. As an intermediate target, we have to achieve clinical remission plus normalization of the fecal calprotectin. And as a long-term target, we have to achieve endoscopic healing plus normalization of the quality of life. As I said before, that histological healing will be added to the target soon. And why is that? We know that the patient who achieve histological healing will be less likely to develop relapse. So we have evidence-based that patients who achieve the histological healing will have longer relapse-free survival. And also, patients with histological healing will have lower rate of complication, including surgery, hospitalization, and risk of colon cancer. Although it is a really tough target, but it's worth trying to achieve it. We know that histological remission come in concordance with endoscopic remission, but it is tougher target. That's why less patients will achieve this target. And the concept of disease clearance, we'll hear about it more and more in the upcoming conferences and any gathering in patients for IBD. So, and the concept is to achieve symptomatic remission, endoscopic healing, as well as histological healing, and maybe in the future we'll aim to achieve also molecular healing. And this strategy not only limited to patients with ulcerative colitis. We know that also Crohn's disease, we have to follow the same strategy. We have to aim higher. We have not to limit our target to clinical remission, and there is impact in doing this. So patients who achieve endoscopic remission will have lower complication and lower chance for progression of the disease when you compare it with the patient who achieved only clinical remission. And in this regard, I'd like to discuss this very important paper that discussed the efficacy of vedolizumab on the endoscopic remission in patients in Crohn's disease. And interestingly, also, they discuss the outcome in regard of the radiographic and histological remission. And the vedolizumab, just to remind you about the study design, that it is single-arm, multi-center, open-label study, and it is showed significantly and nicely that vedolizumab was able to achieve endoscopic response rate at week 26. Almost 25% achieved this target, and half of the patient achieved endoscopic response at week 52. When it comes to radiographic remission, we can see that a Maria 7 remission rate was achieved in about 20% at week 26 and 34% at week 26. When it comes to the histological response in case of colonic Crohn's disease or the colonic taken from the biopsy taken from the colon, almost 25% achieved this target at week 26, while in the ileal biopsy, almost 28% achieved that target at week 26. More tough, more difficult, more challenging target is histological remission, and that was achieved in 15% at week 26 and 20% at week 52. Last thing, I'd like to share this recent publication talking about sequencing of biologics in patients with IBD. That was among patients in the UK database, included about 13,000 patients, and we compared the efficacy of biologic in patients with ulcerative colitis as a first agent and as a second agent, and then in Crohn's disease, again as a first and second agent. So in ulcerative colitis, vedolizumab was the winner as a first-line treatment in patients with ulcerative colitis, and again, it is the winner at the second line after failing of adalimumab and infliximab. It is important also to mention that anti-TNF will not be affected if you use it as a first line or second line. You can see here in the graph, vedolizumab showed nice superiority in purple against infliximab in red and adalimumab in blue, as well as golimumab in green when you use it in ulcerative colitis as a first agent. When you use vedolizumab also as a second-line agent in patients with ulcerative colitis, it still showed superiority to infliximab in red in the first graph and to adalimumab in the second graph. In Crohn's disease, it just confirmed what we already know, that infliximab was superior to adalimumab in case of perianal Crohn's disease. And after the failure of anti-TNF agent of secondary loss of response, both ustekinumab and vedolizumab showed superiority to anti-TNF agent. And this is my take-home messages. I hope that I was successful to convince you that it is the time to limit the use of steroid for our IBD patients. Early treatment and early escalation are the keys to minimize the long-term damage. We have to aim high and don't limit your target to clinical remission. Consider all the factors carefully when you select the biologic agent, and thank you so much.
Thank you so much, Dr. Sles. Please have a seat, and the floor is now open for questions. Please reach to the mic, and we'll be happy to take any questions. Now, if I may start with a question about the use of immunomodulators. Do you generally use immunomodulators in combination with vedolizumab when managing IBD patients requiring escalation to advanced therapy?
Thank you. It is really nice and important question. So we usually tend to use vedolizumab as a monotherapy, especially if it is first line. But if it is used as a second line and the patient was previously on anti-TNF and combo, I don't tend to stop the immunomodulator directly. I'll keep the patient till I achieve at least my targets, and then I'll consider stopping the immunomodulator.
And I think I like the pyramid you showed about the safety data on monoclonal antibodies, including anti-integrin and interleukin 12-23. I would be interested in your thoughts about the use of vedolizumab in combination with other biologics. We've seen recently the publication of the Explorer trial in combining Vedo and adalimumab in Crohn's disease, and doesn't seem that there is a safety signal. Is that in line with other studies?
Yeah, I second you, Dr. Al-Amil. Yeah, I guess there is no any safety signal showed in that study, and I guess we'll see more and more of the trials of combination of biologics in the near future.
Okay. Any questions from the audience? I know, Professor Nahla, you're working on pregnancy guidelines. Do you recommend continuing these monoclonal antibodies during pregnancy?
Thank you, Dr. Turki. I think this is important patient population group, being our patient, 50% of our patient female and 50% in childbearing period. Also, the piano registry was mainly, they look at the anti-TNF. However, small number was on vedolizumab. More growing evidence now and more data on vedolizumab in terms of looking, and ustekinumab in terms of looking at the fetal blood level compared to the maternal. It was reported to be only few, the level is low compared to the maternal, compared to anti-TNF, which is almost double in the fetal level. The vedolizumab, ustekinumab is there, but at a lesser extent, and all the outcome in terms of the fetal outcome, in terms of infection, developmental delay, and the risk of side effect of vaccination. Also in vedolizumab, ustekinumab, a small number, but it is very reassuring. And despite being detected in minute amount, still it is not having adverse outcome on the fetus. So in the latest consensus, Saudi consensus on pregnancy on IBD that accepted in Saudi Journal of Gastroenterology, but not yet published, we recommend that it is low risk, and we advise to, it's conditional to continue, but we are towards continuing adalimumab or vedolizumab. However, anti-TNF, we have clear data that to continue small molecule until further data, we are recommended to stop it 3 months prior to the consent. Thank you.
Okay. Dr. Al-Bashir has a question.
Thank you, Dr. Imam, for the great talk. For patients who are not responding to Vedo, any rule for shortening the interval or intensifying the dose? That's the first question. The second question, I know you talked about yesterday about the cancer in IBD. Is it truly that Vido, being a gut selective, is it the preferred agent in patient with both IBD and solid malignancy?
Thank you so much for the nice questions. I guess it is really important questions. For the first one, we used to shorten the interval for patients on vedolizumab, and I guess good percentage of patients respond to this strategy. And the second question, yes, I guess from the recent publication for Dr. El-Bawardi, it showed safety really for the use of vedolizumab in patients with recent or even active malignancy. So we know that theoretically it is a gut-selective agent, and also from the evidence also showed safety of the use of vedolizumab in both cohorts, recent and active malignancy in patients with IBD.
Thank you, Dr. Ayman. Nice lecture. My question about patient with secondary loss of response to infliximab admitted with acute severe ulcerative colitis. Any role of vedolizumab in this setting? Thank you.
So you mean is the patient inpatient or outpatient?
Inpatient, admitted acute severe ulcerative colitis, already was in infliximab, but loss of response.
So the setting is acute severe UC who didn't respond to infliximab, right?
He was on infliximab, but now he's not responding.
So acute severe UC.
Yes.
And he was maintaining as a home medication infliximab.
Yes.
There is some data supporting the use of tofacitinib, and also we have option of cyclosporin, and also you have to keep the surgeon on board. It maybe needs colectomy.
Thank you, Dr. Thabit. So I think the point that Dr. Sles is alluding to is a very important point. We stick to the rescue therapy using either infliximab. In this case, the patient had previous exposure to anti-TNF, so infliximab is probably not the best option. So what we do, and we had a case where we used cyclosporine intravenously, and once the patient responds, you can't pursue other advanced agents, including vedolizumab or other agents. Any other questions? I just have a quick announcement to make. There is a change in the schedule, so we'll have the state-of-the-art lectures immediately after the satellite symposium, and then afterwards we will have the SGA awards without a break. So we'll have the lunch break after we finish the whole conference. So it will be state-of-the-art lectures, and then SGA awards immediately, so to give people time to catch their flights. So that's perfect. Thank you so much, Dr. Sles. It's a really pleasure to introduce the co-chairs for the next session, the state-of-the-art lectures. We have 3 outstanding talks. I'd like to invite Dr. Ayman Gregory from King Fahd Military Hospital here in Jeddah, who's chairing the session, co-chairing it with Professor Fahd Al-Sahibani from King Faisal Specialist Hospital and Research Center, and they will be chairing the session and introducing the speakers. Thank you.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum, and thank you for all of you for staying to the end of the presentations today. It's my great pleasure really to introduce the first speaker, Professor Lisa Sharkey. Professor Lisa, she is a consultant gastroenterologist specialized in nutrition. She is working currently in King's College Hospital in Dubai. She has been working before for many years in Cambridge University Hospitals. She is passionate towards clinical nutrition, and she has been with us for the past 2 days in the clinical workshop with nutrition. She has a lot of publications and a lot of work with the clinical nutrition, intestinal failure, and transplantation. Professor Lisa, the mic is yours.
Thank you so much. Thank you to the SGA leadership and the scientific committee for asking me to come and talk. It's been a wonderful few days. I've learned so much. Thank you. So we're going to talk about short bowel syndrome. No disclosures, and this is the structure of my talk. So we obviously need to start with some definitions, background, etiology. I want to talk a little about symptomatic and nutritional management, a little bit about parenteral nutrition and medications in short bowel, and then spend most of the talk probably talking about the complications, how we can prevent and manage them. Lovely. So intestinal failure has recently been quite well defined, and we commonly use this definition from ESPEN. So it describes the process, the reduction of gut function, and the consequences. You need intravenous supplementation to maintain health or growth in the case of children. But short bowel syndrome is actually quite less well defined. So we can think about it as a reduction of gut length such that you cannot maintain on a normal diet, whatever normal is. Important to remind us what ultra-short bowel is. There's some disagreement on this, but most of us would consider 20 centimetres of residual small bowel to be ultra-short. And you can have short bowel syndrome with intestinal failure, or you can have short bowel syndrome without. And there's a critical kind of length of short bowel that probably determines whether you will have intestinal failure or you will manage with adapted behaviours. And that is around 100 to 120 centimetres if you've just got small bowel, so if you have an end jejunostomy. If you've got some colon left, then depending on the length of the colon remnant, somewhere between 50 and 80 centimetres should be enough for you to manage without parenteral support. And if you do manage without that parenteral support, your patients will probably have had to adapt in some way. So they may be eating more calories and macronutrients than expected to account for the malabsorption. They may need some oral supplementation of vitamins and certain electrolytes. So when it comes to the causes, I think we are mostly as a group dealing with adults. However, children with intestinal failure and short bowel syndrome are increasingly surviving through to adulthood, and therefore those of us looking after these patients need to refamiliarize ourselves with things like gastroschisis and necrotizing enterocolitis and some of the strange congenital malformations that can happen. Our pediatric colleagues are looking after these children exceptionally well. They're coming through to adulthood, and then we need to transition them over to our care. But for adults, the etiologies are mainly vascular disease, Crohn's disease still, though we hope that in future years, as we use biologics earlier in the course of disease, as we've elegantly just heard, that the frequency of short bowel with Crohn's will reduce. And then there are some other uncommoner causes, post-op complications, trauma, certain tumours. In order to understand the consequences of short bowel syndrome, we have to remind ourselves of the physiology and anatomy of various segments of the GI tract. So the key points about the jejunum are that it's good for carbohydrate, protein absorption, it's good for iron absorption, but it's pretty leaky. The transit through it is very fast, and a vast volume of fluid goes through it. So that means that patients who just have that part of the gut left often have significant fluid balance problems. The ileum has generally slower transit, but it is responsible for some key absorptive capacity, so if you're missing that segment, we need to manage those. And the colon has a key role, of course, in water absorption. It translates the 5 or 6 litres of fluid that enters it to around just 500 mils in feces normally. It's also got a role in slowing GI transit through some enterohormonal effects, and it can be key in terms of some absorptive and some metabolomic activities. So that we talk about 3 anatomical types of short bowel syndrome. Type 1 and 2 are the ones that we worry about. Type 3 is less common, and actually those patients don't tend to run into much in the way of nutritional problems. So type 3, you have jejunum, a segment of ileum, ileocecal valve, and usually full length of colon. The type 1 anatomy is the end jejunostomy patient. That's the most common type of short bowel, and the critical length is around 100 to 120 centimetres. Below that length, they will probably need parenteral support. Above that length, as long as it's good quality bowel with normal-ish motility, they should be able to manage without parenteral support. And then the type 2 anatomy is the jejunocolic anastomosis, or JCA, which is still a significant proportion of patients. The critical length there is somewhere between 50 and 70 centimetres. It's quite variable, to be honest, depending on the amount of colon left. Around half of the colon is thought to be equivalent to an extra 30 centimetres-ish of small bowel in terms of absorptive capacity. So my overall approach to the patient with short bowel is along this schema. So we start with fluid management. So particularly that type 1 anatomy, that end-jejunostomy patient, you might inherit them in a very fluid deplete state. We'll talk about it in a second. So fluid management is the key first priority to stabilize them, and they may be very volume deplete and need massive amount of fluids depending on what's been happening to them. Then you need to think about your nutritional management, and that of course is oral and parenteral. And are there any specific nutrients that you need to look out for based on their anatomy and what segments of bowel they've lost? Monitoring, of course, and that's not just clinician physician monitoring, that's dietetic and other members of the MDT monitoring as well. When it comes to complications, we'll talk a little bit about these. So there are some complications directly related to the administration of parenteral nutrition and some related to their residual anatomy. And finally, we need to think about intestinal rehabilitation, and that is about maximizing what residual absorptive capacity they have and thinking about adjunct treatments, maybe GLP-2 analogues, maybe transplant that I'll talk about briefly. And not to forget, the aim of management of a patient with short bowel syndrome is to achieve oral or enteral autonomy if possible. If not possible, to make sure that they're on the least amount of parenteral support possible. We, of course, want absence of complications and optimal quality of life. In terms of symptomatic management for a jejunostomy patient, I won't go into this too much. We talked about this in detail at the workshop, and there are some excellent guidelines from Jeremy Nightingale at St Mark's. But what I do want to say is that when you're managing a high output jejunostomy, you've got to be systematic and not do too many things at once. Because you need to know which interventions are having a good effect. So patient education is really important, a systematic approach is really important, and when it comes to the medications, starting low and increasing. As you may know, you can get up to very high doses of anti-secretory and anti-motility medications with these patients in trying to manage their fluid balance. So in the nutritional management of a patient with type 1 anatomy or a jejunostomy, a lot of it is around fluid balance. Their absorption will be reduced, but they may absorb, depending on the bowel length, up to 70% of their protein and carbohydrates. They will get fat malabsorption, but unlike other patients with short bowel, that doesn't tend to cause too much in the way of complications, and they may absorb some of the fat, so we do usually recommend that they have some fat incorporated into their diet. In order to help retain the fluid in the jejunum and not cause high output stoma, we also recommend a high salt diet. There are arguments for and against fibre in this group of patients. On the one hand, fibre should slow gastric emptying and perhaps slow small bowel transit. On the other hand, it tends to draw water into the lumen of the gut and therefore might increase stoma output. So we usually say, let's do a trial of soluble fibre and see. If they get a positive response, of course, continue. If they don't, go back to a low fibre diet. And if you're trying to manage this patient without parenteral support and you're thinking about giving them an oral nutritional supplement, avoid the elemental or semi-elemental formulations as they can drive an osmotic diarrhea, so stick to a polymeric feed. The other type of anatomy, the jejunocolic anastomosis, they don't tend to have high outputs, high fluid losses, so you don't tend to need that sort of approach. And also, you've got the opportunity to maximize the benefits of the colon in continuity. So the colon can salvage up to an extra 500 calories a day from unabsorbed carbohydrates. But there are some potential problems with that I'll talk about in a moment. So you tend to advise complex carbohydrates rather than simple sugars. These patients can get a lot of steatorrhea. They're missing the terminal ileum where the long-chain fatty acids are usually absorbed, and they're also often bile salt deplete. So we tend to say that they need a minimal fat diet. but particularly if they're not on parental nutrition, so they're not getting fats from another source, you need to think about their risk of essential fatty acid deficiency. And I have seen some patients with that. They get the characteristic dry skin, dry nails. You can measure their essential fatty acids. They can be very low. In theory, medium chain triglycerides are better tolerated because they don't require the usual bile acids for absorption, but they're not particularly palatable. If anyone's tried coconut oil, it's not particularly palatable. In extreme cases, if you've got a patient not on parental nutrition with essential fatty acid deficiency, you can get them to rub sunflower oil into their skin. It's obviously quite time consuming, but it can give them just enough absorption of essential fatty acids to manage. The other key thing with patients with type 2 short bowel anatomy is that they need to have a low oxalate diet. We'll come back to that in a second. So briefly, for parental nutrition in short bowel syndrome, like I mentioned, not all patients will need it. It will depend on their anatomy and the degree of intestinal adaptation that they've undergone post-surgery. But remember your approximate guides: 100, 120 centimetres for jejunostomy, 50 to 70 centimetres for jejunum with colon. But that does assume that what is left is good quality, which may not always be the case, and it does assume a degree of adaptation post-resection. So setting up a patient on home parental nutrition, even if you expect it only to be temporary, may still be worth it, because that adaptation process can take many months. Depending on your availability, your exact prescription will vary, depending on what the patient needs, what you've got available, and sometimes there's a degree of compromise needed. In general, a patient with an end jejunostomy is going to need 7 nights of parental nutrition because of the fluid balance issue. A patient who's ultra short might even require 24-hour infusions because their fluid losses are so extreme. So sometimes we'll have an ultra short patient on 12 hours of parental nutrition overnight and then just simple replacement crystalloid fluids during the day. And all of the guidelines recommend 3 to 6 monthly monitoring of various micronutrients for patients on parental nutrition. I just wanted to mention about drug use in short bowel syndrome, because this is something frequently not appreciated. They haven't got normal absorptive capacity or absorptive length, so please bear that in mind when you're prescribing something. So the advice is use liquid formulation or crush the tablets wherever possible to speed up the absorption process. Think about whether buccal or rectal administration is going to be possible. Avoid anything delayed release and avoid anything that's got sorbitol in it, as that will exacerbate diarrhea. There are various biopharmaceutical classification tools that you can use, but what you really want is a drug with high solubility and high permeability to maximize the chance of that being absorbed. A couple of points about drugs that we often use in short bowel syndrome. Loperamide normally undergoes a significant amount of enterohepatic recirculation. You're not getting that in short bowel syndrome, and that's why we sometimes need these very extreme high doses of loperamide. We do say we can go up to 32 milligrams 4 times a day. There are some recent concerns about QT prolongation with these very high doses of loperamide, so you would need to get baseline and follow-up ECGs. And often we have short bowel patients on PPIs. Just bear in mind that you need about 50 centimetres of small bowel to absorb PPIs, even the quick release ones. So if your patient has less bowel length than that, you're going to need to give it IV. Okay, moving on to complications. We've got metabolic bone disease is pretty prevalent in patients with short bowel syndrome. As you can see here, there are some very high potential rates in patients who are on parental nutrition with short bowel. Lots of reasons for it, some specific to parental nutrition, some specific to their disease, some patient factors like smoking, immobility, and some medications, of course, steroids, low molecular weight heparin, etc. The basics that we should do would be the panel on the left here. So check vitamin D, PTH, calcium excretion, get a DEXA, make the adjustments that we need to in parental nutrition, and that would be making sure we're not overfeeding them with protein, making sure they're getting enough calcium and phosphate. When it comes to treating, so the panel on the right, I think if you get to this point, you probably want to get your metabolic bone team involved. Renal stones can be a big problem for patients with the jejunocolic anastomosis anatomy. Now, that is often patients with Crohn's who've undergone resections, so I think it's really important that we all understand this. So, of course, dehydration predisposes patients to any type of kidney stone, but the issue with jejunocolic patients is that they have unabsorbed free fatty acids hitting their colon. At that point, those free fatty acids tend to bind calcium. That takes away the calcium that previously would have bound to dietary oxalate. So the oxalate is free to be absorbed across the colon lining and excreted in urine. There are some other things that can exacerbate that. So in terms of management, we obviously advise a low oxalate diet. Calcium supplements can actually help if you increase the amount of calcium there to bind the oxalate. And in terms of the parental nutrition, you want to make sure that they're adequately hydrated. Citrate and magnesium can also bind oxalate, so supplementing those can help. The other particular problem that the jejunocolic anastomosis anatomy patient gets is something called D-lactic acidosis. This is pretty rare, but it's difficult to diagnose and difficult to treat, so again, I think it's worth you knowing about it. It's a clinical syndrome usually manifest with neurological features that again relates to unabsorbed carbohydrates hitting the colon, plus an alteration in the colonic microbiome to D-lactate producing bacteria. When you measure their biochemistry, they will have a metabolic acidosis, but their lactate will be normal because our assays only measure the L isomer of lactate. So if you have a patient with that type of anatomy, neurological symptoms, and an unexplained metabolic acidosis, this is probably the cause. Treatment is difficult. We tend to get them to avoid too much dietary carbohydrate to take away that substrate from the bacteria, and treat with antibiotics to try and alter the microbiome composition. So a couple of complications specific for patients with short bowel receiving parenteral nutrition, catheter-related bloodstream infections, and catheter-associated venous thrombosis. We want to minimize the incidence rates of these, of course, and there are targets for intestinal failure centers as to the frequency with which these should occur. For the catheter-related infection, the absolute key thing is flawless aseptic technique in accessing the line, whether that's the patient doing it themselves or the caregiver. Where possible, we try and treat these while salvaging the line, and there are a couple of recent adjuncts like antibiotic caps and antibiotic locks that can help reduce the frequency. For catheter-associated thrombosis, the key factor is the tip placement of the line. So the more proximal that is, the more likely they are to get thrombosis. So we want to make sure that it's at the SVC right atrial junction, or at least in the low SVC. And femoral lines are associated with higher risk of thrombosis. Some metabolic complications of short bowel and intestinal failure. One is intestinal failure-associated liver disease, or IFALD. This is either a steatotic or a cholestatic liver disease which progresses from fibrosis to cirrhosis. It has a number of associations rather than a specific cause. Some of the big associations are the amount and type of parenteral lipid that a patient receives and their anatomy. So those ultra-short patients are very high risk, and if there is more than one big risk factor, so such as an ultra-short patient who also drinks alcohol in the red curve here, they are at very high risk. Just briefly, when it comes to management of IFALD, there are some parental nutrition factors, some other patient factors that we need to think about. So we will amend a prescription to try and minimize the factors in the parental nutrition that may be contributing. If you can restore their anatomy or reduce their overall parenteral nutrition requirements, that does help. You obviously want to make sure there's no coexisting liver disease, and you want to think about whether they're a transplant candidate. So we talk about intestinal rehabilitation now rather than intestinal failure, and it encompasses a kind of holistic management approach with the goals that I mentioned earlier about nutritional autonomy, quality of life, avoiding complications, and we should also add in equity of access to some novel therapies. Those novel therapies include, just in brief, glucagon-like peptide 2 analogues, which have been clearly shown to reduce parenteral nutrition requirements, and there are a number of these now available on the market. We recently talked about not forgetting our surgical colleagues. The same is true for short bowel syndrome. If there's any distal bowel not in continuity, you always want to recruit that back in, because that will reduce their requirements. And there are some techniques about intestinal lengthening which are suitable for a small percentage of patients with short bowel. Also, for a small percentage of patients, there is the option of intestinal transplant, traditionally reserved for patients with short bowel on parenteral nutrition with complications related to that. But I think as the outcomes continue to improve, it's being offered at an earlier stage for quality of life and avoiding complication reasons. Looking after a short bowel patient or a patient with intestinal failure is not a solo job, and you very much need a multidisciplinary approach with all the team members involved here. So we've gone through a list of problems and complications, but what I haven't stressed actually is how rewarding this is. So particularly for interns and fellows, if there are any in the room, this can be a really satisfying area of gastroenterology to be involved in. That feeling if you manage to wean a patient off parenteral nutrition is just amazing. And if you don't, being able to support patients on parenteral nutrition through getting married, having children, traveling the world, kicking things off their bucket list, it is just really satisfying and a really rewarding part of the job. If you're interested, there's a fantastic textbook. The second edition has just been published. But otherwise, thank you so much for your attention.
Thank you very much, Prof. Lisa. And we will leave the questions till the end of the 3 lectures. We will introduce a second speaker. Dr. Muhammad Karim Sharif is a consultant gastroenterologist currently based in Mecca, King Abdullah Medical City. He completed his gastroenterology training in Newcastle and then moved to Cambridge University Hospital for research endoscopy fellowship. During this time, he was granted as a BUPA Foundation Award to join 3 years Medical Research Council Career Development Fellowship, during which he carried out peritoesophagus-based research leading to an MD equivalent to PhD from Cambridge University. He was awarded the Sir Leonard Webby Medal, the most prestigious award given in recognition of outstanding work in research dissertations in Cambridge University. His speech about building a research culture in busy gastroenterology department, challenges and opportunities. Welcome, Dr. Muhammad.
Assalamu alaikum, and thank you very much for your kind introduction. Today I'm going to be talking about building a research culture in a busy gastroenterology department. This will be purely from the focus of a Ministry of Health hospital, which is based in the Western region where I come from. I would like to, while I was doing this presentation, I realized there is enough research culture in Saudi Arabia. So I would like to tweak my talk slightly, if the chairman does allow me, to make it building or conducting a good quality research in a busy gastroenterology department. Given the amount of lectures that you've already heard, I'll try not to mention inflammatory bowel disease in my talk. I would like to share the challenges and the opportunities that I think that we came across. I would like to start with emphasizing why research and why we should conduct research. Research is essential for healthcare, especially in times of crisis like COVID-19 pandemic. Research can help us find solutions It helps us improve quality of care and save lives. Research can be rewarding, both for us as professionals and individuals. However, I do recognize that it can be daunting and challenging if you really don't know where to start. However, it's never too late to get involved. And that's the reason why I feel that we should all try and embrace research and have people around who can support and encourage us to do so. We all well aware of the story of COVID-19, which spread exponentially, causing devastation in all aspects or all parts of the world. In a desperate and despondent situation, everybody turned towards research, and ultimately research did deliver. With the vaccination and the amount of research that went through, WHO ultimately did say that pandemic was over. The other thing that research did create was an unprecedented focus on health evidence. This was not just at the government level or non-government organization. Even ordinary members of the public turned towards research, came up with ideas like garlic, ultraviolet rays, and alcohol sprays could help with COVID-19. However, these were not beneficial ideas. But the notable innovations and fast-track collaborations did ultimately pay off. And as the vaccine campaign was laid out, millions of lives were saved. In addition, there was an economic benefit to the whole world, which ran in trillions. This clearly manifests how research had both economic benefits and life-saving effects. COVID, in addition, had many more examples. One of them that I would like to focus is the recovery trial. It was a testament to the power of clinical research in times of crisis. Despite the challenges of COVID-19, recovery trial used available resources with minimal funding. I mean, even though it's £2 million, if you look at the multi-center trials that are done these days, they cost billions. And one of the things that UK had to offer were their pre-existing clinical research networks. And that's what the recovery trial did. Majority of the recruitment was through the UK, and using simple medication, dexamethasone, it did show huge benefit economically. The medication that they used just cost about £5. And this equated to an investment of just over £2 to save lives. I hope I've tried to convince you the need for research in the healthcare system. And now I would like to draw your attention to see how engaged the clinical physicians are. This is the survey that was recently conducted by the Royal College of Physicians, which showed that nearly about 55% of respondents in UK, which is well known for the research that they do, assisted in some form of research. And a similar kind of research done by Iman Soulais's group surprisingly showed that 86% of the respondents, mainly from gastroenterology background, were involved in research, not just in assisting research, but as primary investigators or co-investigators. And I do believe from my own personal experience that this is indeed a true reflection. Despite a significant higher level of involvement of research in Saudi Arabia, the clinicians face much more pronounced difficulties in conducting research. If you look at the barriers that the clinicians in UK face with regard to conducting research, the main barrier is allocated research time, but they have easy access to research funding and research infrastructure. But when you look at what the problems the clinicians in Saudi Arabia are facing, you realize that a staggering 80% of them do not have access to proper funding, nor to proper infrastructure. To further look into these challenges that I would like to list through my experience, I usually see research is built on 3 pillars. It requires people, it requires a place where you can do research, and of course it does require money. But depending on the type of research that you'd like to do, the importance of each pillar actually varies. You may not need too much of money, as the recovery trial showed. So focusing on the challenges, the first challenge is the people, the human power, the human capacity. What I see is a problem here is there is lack of mentors that can guide you through conducting good research. Support staff is not available. You find it difficult to find trained researchers, leading to lack of awareness of what is around, and statistical support, which is one of the important factors of conducting research, is difficult to come by. The other factor is financing. It is difficult to find funding, and people are not aware of the available funding bodies. And even if you do find funding bodies, what you need is support. Grant application is not easy. It's a complex process. You need to meet timeframes. You need to meet the objectives of the granting body. One of the most important and key factors in getting grants is knowing the budgeting, the economic management of the budgeting, and reporting this budget appropriately. So finance is a key aspect to your research. The next is the place, the logistics of conducting research. There's limited infrastructure in most of the Ministry of Health hospitals. The training opportunities are limited to come by. Developing good teamwork and networking can be an issue. Sometimes you don't even find a desktop where you can work on. No good scientific libraries are available. And of course, research time is always a challenge. Having listed the challenges, before I enumerate the opportunities that are available, I would just like to pause here and look at the status of clinical trials, which is just a reflection of how much research is happening. This is from a recent report published in Nature by King Abdullah International Medical Research Center that estimated that despite Saudi Arabia consuming about 0.5% of the global pharmaceutical market, it contributes to a trivial 0.02%. The number of trials that are conducted here are far less than what is conducted in the United States. These issues are very well recognized by the organization, and it is taking great steps to address this. They are going to increase the number, and they are working towards this, increase the number of trials. And one of the things that they actually highlighted in this report was that Kingdom of Saudi Arabia has huge number of patients to offer for recruitment, as most of them are not yet into any trials. And I think this is a positive opportunity for conducting clinical trials in Saudi Arabia. The opportunities, what are the available opportunities? One of the pillars, as I mentioned, the people, the manpower. Research is an essential component of medical profession in Saudi Arabia. It is considered a prerequisite for moving up the ladder in the career. And that's why after having gone through this, I realized there is research culture, but what needs is good research trials. The Saudi Commission for Health Specialties has made research an essential part of the curriculum. So for medical students, interns, residents, and fellows, they're all encouraged to have research experience to move up the ladder in their careers. And the availability of this manpower, if utilized in the right way, provides a great opportunity of conducting quality research. They are available for you to collect data, to write up protocols, recruit patients. It's a win-win situation, both for you and the doctors, junior doctors, trying to get research done. The other opportunities is the infrastructure. Saudi Arabia has excellent universities. Some of them rank within the first 50. They have good scientific libraries, good research departments. They have good biostatistics departments, which are great asset. No matter which region you are in Saudi Arabia, you will find a good university very close by. Collaborating and having a friendly attitude with these people can be a key to opening these resources. Funding, right? This is the main issue. However, the vision, the Saudi vision of 2030 is paving the way for funding. The vision sets to invest more than $62 billion into healthcare. This is going to trickle down to the research, as research is an important pillar of the vision. The vision is a testimony to the country's commitment to innovation and progress in research. And working towards this vision, it has already established some well-funded research organizations like the Saudi NIH, the Research Development and Innovation Authorities. These organizations not only provide research support, they have huge grants, which they are giving away, up to 10 million Saudi riyals, depending on the type of research that you're doing. And the vision has strengthened the existing organization called CACS. Apart from this, we already have existing places with excellent research record that are good resources. Again, the key to tapping into these resources is collaboration. And I believe many individuals here today are part of these organizations. And SGA gives an excellent opportunity to network with these people and tap into these resources. Apart from the government agencies that are providing support, the other opportunity is a pharmaceutical company. Pharmaceutical companies are booming in Saudi Arabia, and it is set to increase. This boom will move from 28 billion to 58 billion, and this will translate into conducting further clinical research. Now, having listed the challenges and opportunities, as a case study, I would like to share our own personal experiences. How, in our department, we navigated our challenges, embraced opportunities, and conducted high-quality research. I work in a smallish kind of a hospital compared to the big hospitals that are around in Riyadh. It's called King Abdullah Medical City. Being small, though, it has a giant vision of conducting research. So if you look at this hospital, it is situated in a beautiful city, surrounded by beautiful mountains. But when it comes to clinical research, it's quite barren. So our starting point was a scratch. This was quite challenging for us. But what we had was passion for research, and we also had the research know-how. This actually propelled us into the research field. So how did we start? We had a very friendly and supportive staff at the King Abdullah Medical City that provided a great foundation for building a research culture. We started off with research education. Simple things like educating them on good clinical practice, conflict of interest, and different aspects of the research. We were able to convert, or should I say revert, the busy endoscopist into research geeks. This actually generated huge ideas, the Eureka movement, and this encouraged us to apply for fundings. Unfortunately, being in an embryonic stage as we were, we expected that this challenge is going to be difficult to overcome. We did identify funding bodies, and we did apply, but there was no response. Now, these are disappointing moments, but we remained motivated. We kept looking for opportunities. So we had staff, we had enthusiasm, we had ideas. We put this together, and we looked around in our own hospital. What do we have? Now, we came up with the idea that we would like to conduct a study, a randomized controlled trial of general anesthesia versus conscious sedation for ERCP. And we found a partner in anesthesia department, which we work with on a daily basis, which does all the sedation for endoscopy. They're very keen to join us in research. Now, this is marriage made in heaven. We went through all the steps of research, but as it happens, cracks started to develop in our relationship. Tiny issues like who's going to be the principal investigator, who's going to be the first author, stalled this process. While we are trying to negotiate and find a middle ground, we realized the idea was already out there, and someone had already published this paper. After so much of hard work, effort, this was shattering. This was mission failed. But the enthusiasm and the commitment, we did not give up. This does happen when you're conducting research, but there's always a way out if you remain motivated to your goal. If you look at this, they conducted use of GI versus conscious sedation in high-risk patients. So we said, okay, let's go back to the drawing table and see what we could bring out of this. And we said, okay, they did it in high-risk patients. We will do it in average-risk patients. And based on this idea, we went through the whole process of applying for IRB, got the IRB approval, got the trial registered, a long time. And with the support of our staff, we started off with recruitment. And as I mentioned, we did find it quite easy to recruit patients. We had everybody in the team involved, the physicians, the nurses, the research coordinators. We had the logistics up. We were monitored every 3 months. We never gave up. We had to go through the regulatory submissions. We did ultimately conduct the trial, collected the data, analyzed the data. This was not easy. COVID hit, the uncertainty of COVID, the slow recruitment. We had issues with documentations. Being clinicians mainly, we do not document things properly, but when it comes to research, every tiny bit had to be documented, and this was highlighted again and again during our monitoring process. But we learned, we innovated, we stuck to it. And ultimately, we did manage to write the manuscript. And as happened, we thought this is a randomized controlled trial. We approached the best possible journal. The initial response was a rejection, a disappointment, a low, but we did not give up. We resubmitted and got revisions and ultimately approved. And here's the crowning glory. Our randomized controlled trial does get published in Gastrointestinal Endoscopy Journal. This is a true testament to the efforts that were put through to our department. Teamwork, hard work, commitment, don't give up. Ultimately, you reach the success. And we are pleased today that this research was just not done for the sake of doing research, has gained importance. We have already had 5 citations in a short period of time since it has been published. This is our journey that I have encapsulated in few slides. It took us years to go through this, but we are proud of our team, of our department. And before I end my talk, I'd like to highlight another example. If I may, and given the permission, is Saudi Gastroenterology Association itself. through its flagship publication, the Saudi Journal of Gastroenterology. What I have noticed from my perspective, the Saudi Journal of Gastroenterology has grown steadily, and the impact factor today is 3. This is not easy. And I'm quite sure the editorial board and the SGA have their own story to say. They have been through challenges, and I'm quite sure they have embraced the opportunities. And this journal actually provides an excellent platform and an opportunity for people who want to do research and publish. And indeed, it has. It has given a platform for some of the gastroenterologists here, and the notable faces are there. We all recognize them. They've had some big, high-citing publications. So this is a huge opportunity, and I hope that SGA continues to provide this platform, encourage more research, come up with schemes for the budding junior doctors and consultants, junior consultants working in gastroenterology. Of course, the journal has now started charging for its publications. Before it did not, but it is an economic success. That's what I would like to call it. So in conclusion, we face many challenges in building a research culture, but we need to overcome these challenges and seize the opportunities that are available around. We need to collaborate, learn, and innovate. We need to make research a priority and a passion. If a small hospital like us can do it, I feel anybody can do it. Before I end my talk, I'd like to thank everybody in my hospital, especially the principal investigator of the study, Dr. Adnan, who, out of his busy schedule, in spite of being an executive director, in spite of being a clinician, had found the time to conduct this research. The head of the department, Dr. Abdulaziz, Dr. Khan, Dr. Saad, Yasser, Salem, Mona, the associate consultant, Zafar, Laik, all the assistant consultants who assisted us, Usman, Mahmoud, Inaya, Hifni, and I would like to give a big shout out to the nurses of our department headed by Ibrahim. Thank you very much for your attention.
Thank you, Dr. Sharif. If you can join us here in the podium. So it is my honor and pleasure to introduce the last speaker for the state-of-the-art lectures of the SGA Symposium, Dr. Mohammed Al-Bur'i. Dr. Al-Bur'i is a professor of medicine and gastroenterology at Al-Azhar University. In fact, he graduated from Al-Azhar in 2002 with an honor degree. After that, he did some training at Al-Hussein University Hospital, then back to Al-Azhar doing his research in liver cirrhosis and enzymes of the liver. And after that, he did some training in Germany. And now he's actually going to talk to us with something different, which is artificial intelligence in the endoscopy unit. Dr. Al-Bur'i.
Thank you very much, Dr. Faz Suhaibani, and I'd like to thank the Saudi Gastro Association for inviting me. It's an honor to be among this group of international experts in this excellent symposium. So I'll talk about artificial intelligence in the endoscopy suite. Is a little bit broad term, so I will try through the presentation to cover the most important things that I have noticed. So can I have a flipper? This one? Yeah. No. I have no disclosures. My agenda will be an introduction about what's artificial intelligence and some applications in upper GI, biliopancreatic endoscopy, small bowel endoscopy, and lower GI endoscopy. I will also highlight some limitations in the models used nowadays and take-home messages. What is artificial intelligence? Artificial intelligence is the science of making machines or computers smart enough to perform human tasks like visual perception and voice recognition. There is what's called computer-aided diagnosis, or CAD. It is a technology that enables machines to process information and function at or above the human level. It is a mathematical prediction technique that automates learning and recognizes pattern in data. When you see for the first time this model, you feel that it's more an engineering model. It's really an engineering model. This is a simplified form of the artificial intelligence model, which is the unit of the AI, which is the neuron. The neuron utilizes some inputs, which X1, X2, X3, and gives them weight, specific weight for each input. And inside the computer, it processes this information to give you an output. When you make a more complex one, you make multiple layers of these neurons to further make more details and more classification of the input information. This is an example of the artificial intelligence used in detecting breast lumps or breast cancer. When you take the mammography picture, which is an input, and this goes through different stages of analysis inside the computer to give you an output at the end, which is malignant or a benign lesion. There are some terms used in the artificial intelligence like machine learning, which is providing the computer system the ability to learn from past experience without explicit programming. Or the deep learning, which is a more advanced one. It's a more advanced one of the machine learning that relies on multi-layer neural network capable of learning without supervision from unstructured or unlabeled data. So the machine learning is the primitive form, and the deep learning is the more advanced form of artificial intelligence. When you reach the more advanced one, is computer vision, is a technology allowing computer to see and interpret visual content to guide your decisions. This is a diagram of what's called artificial intelligence, which is the general idea, and then you make refining of the data by making the extraction of data and give it to machine, and then the machine can interpret the data. This is machine learning. Or if you have more programming and the machine can itself get the data from the object and analyze it without your input, this is the artificial neural network or the deep learning model, aiming at the end to have what's called machine perception or a computer vision. The computer itself can decide. This is another example, a simple example, where we have the input is a car, and then we do the feature extraction as a human being to give it to the computer, and then the computer through the convoluted neural networks detect the object and classify it either having a diagnosis of a car or not a car. And if you give the input to the computer without doing any extraction of each feature, and then the computer itself detects the object, which is a car or not car, this is the deep learning model. This is another example when we use the features. Here, for example, a cat has 4 legs, tail, and pointed ear, and flat nose. You extract these features and give it to the computer, then the computer identify this is a cat. But the deep learning model, you give them the animal, and they classify it without giving any information. Also, the computer can further classify the object into different types of objects. He can say that this is a car, this is a truck, and etc., and this is a bus. So with further learning and more learning for the computer and giving more inputs and more examples, the computer can himself identify the object in accuracy. Current research on medical image recognition usually adopts the deep learning algorithm based on the convolution neural network. It is some sort of network like the human brain. Artificial intelligence has been used in gastrointestinal endoscopy, including esophagogastriduodenoscopy and capsule endoscopy, colonoscopy, biliopancreatic endoscopy, etc. And it helps the endoscopists to improve the rate of diagnosis of various lesions and reduce the rate of missed lesions, improve the quality of endoscopy, assess the severity of the disease, and improve the efficacy of endoscopy. The use of AI in image recognition mainly plays 2 important roles. Number 1 is computer-aided detection, or CAD-E, or computer-assisted diagnosis, or CAD-X, for the lesions. Here is an example where you use the white light image or the blue light image or the linked color image, and then you process this through the computer to give you at the end a diagnosis for the lesion based on its advancement in the lesion, whether it's a benign lesion or pre-malignant lesions, etc. Here the computer can take the image. Here the first one is the white light image, the second one is the blue light image, or narrowband image, sorry, and the third one is the image enhancement, and then the computer detects the polyp and then draw the map with colors around the polyp and detects which lesion or which area is a pre-malignant area. I will go through some applications in the upper GI endoscopy. For example, we can use it in automatic detection of esophageal dysplasia or early esophageal gastric cancer, assess the cancer invasion depth, and we can detect Helicobacter pylori infection or presence of intestinal metaplasia or gastric atrophy. It can diagnose and characterize subepithelial lesions. I will just mention few examples. This is an example of computer-aided detection of early neoplastic lesions in Barrett esophagus. This study, they used images from 44 patients. They used 100 images of those patients, and then they used the computer-aided detection for diagnosis of the presence of Barrett esophagus. The results was pretty good. With at the patient level, the system achieved the sensitivity and specificity of 0.86 and 0.87 compared to the experts. They used the first one, which was the image detected by the endoscope and then examined by the endoscopist, and this second one was the prediction of the computer in comparison to the endoscopist, the expert endoscopist. The third one and the fourth, fifth, and other one were another endoscopist expert in Barrett esophagus. So it can detect more or less the same, the areas of dysplasia based and compared to the endoscopist. So in conclusion, the automated computer algorithm developed in this study was able to identify early neoplastic lesions with reasonable accuracy, suggesting that automated detection of early neoplasia in Barrett esophagus is feasible. This is another example of artificial intelligence for detection of Helicobacter pylori and its complication. When you look at the first image here, which is the white light image, you find some areas of gastric atrophy and maybe intestinal metaplasia. This is with white light endoscopy. When you apply image enhancement like narrowband imaging or blue light imaging or linked color imaging, you enhance the features by detecting more lesions which are appearing down, light blue or yellow or even red. So these areas with light blue is a form of gastric atrophy. Areas with yellow could be areas of intestinal metaplasia. Also, the artificial intelligence was used for the classification of IRB. I had heard about the nice motility workshop that has been done 2 days before, and we have a lot of problems doing upper GI or high resolution manometry in positioning of the catheter, which is present in the right position or not in the right position, calculating the IRB. This Inceptive V3 deep learning model was used to classify the images and also to put a diagnosis as a correct or a failure catheter position and determine the integrated relaxation pressure at the lower esophagus. Also, this endo-angle model used for detection of non-cancerous lesion in the stomach. It puts a rectangle about on the lesion, and then you can biopsy targeted this lesion. The use of artificial intelligence in biliopancreatic endoscopy, the published literature is predominantly limited. In early preclinical studies, including the application for diagnostic EOS and patient risk stratification, but there are promising application includes optical characterization of strictures during cholangioscopy. This is a nice example for using artificial intelligence during cholangioscopy. They used the data of around 11,855 patients. 9,000 plus were having malignant strictures and 2,000 plus were having benign strictures. They found that they can detect the malignant strictures with the cholangioscopy artificial intelligence assisted, with accuracy reaching 94.9% and area under the curve of 0.988. In a small bowel endoscopy, the algorithms can be applied to the small bowel capsule endoscopy reading, such as automatic detection of lesions or classification of the bowel cleanness or automatic compartmentalization of the small bowel and short reading time to improve lesion detection accuracy. This is an example of a small bowel endoscopy where you can see the lesion, the computer can detect the lesion, and it also can detect the size, measure the size of the lesion, not only detection, and it can also put a three-dimensional. You can change the image direction to have a proper visualization of the lesion. This is another example. When you look at this capsule endoscopy picture, you can difficultly see that there is a small ulcer here, but with the artificial intelligence, it is red in color, and you can see clearly the presence of the ulcer. It can also differentiate between the presence of an ulcer or an erosion and high area of hypervascularity. When you look at this picture, you find a prominent vessel there, but this is not translated into the red color like the erosion. The erosion is red, but the vessel is green or yellow. The applications in the lower GI endoscopy are a lot, and we have a lot of models, and we use most of them in our region. It can be used in detection of colorectal polyps, characterization of colorectal polyps, improving the quality of indicators for colonoscopy, and inflammatory bowel disease, many aspects in the inflammatory bowel disease ranging from diagnosis to detection of dysplasia and assessment of the activity of the disease. This is a small, very small polyp that can be detected only with the artificial intelligence. We can easily miss very small polyps like this during doing colonoscopy. Using the artificial intelligence models or the CAD-E can increase the relative detection of adenoma in the colonoscopy by 30% and can increase the adenoma detection per colonoscopy to 40%. It can also classify the lesions into sessile lesions, polypoid lesion. It can detect the presence of a tool like a snare here. It can also detect the presence of a lipoma. It can help in all the differentiation of the lesion. Also, it can measure quantitatively the preparation. When we depend on Boston bowel preparation scale, which is a rough estimate method for the colonic preparation, but with the artificial intelligence model, you can accurately detect if the patient is prepared and how much is the preparation for this patient. It also has been applied in detection of the colon polyp and in prediction of the histologic characters of this polyp to be malignant or not, and this was consistent in right side of the colon or left side of the colon, rectal lesion and other lesions, etc. In IBD, also it has been used to detect the endoscopic remission, the histologic remission, and the ulcerative colitis endoscopic index of severity score through also the convoluted neural network, where there is an input of the images of the ulcerative colitis patients, and then the computer calculates the probability of the endoscopic remission or histologic remission, also with accuracy reaching 90% and 92.9%. It can be used in clinical trials, it can be used in providing training and disease management. So there are a lot of applications that can be used with the artificial intelligence models that is present nowadays. So this is another example, which is my last example, which is AI-assisted endoscopy for assessing mucosal healing in ulcerative colitis, when they use the iScan TEC image here to draw a map of the activity of the disease to have a numerical evaluation of the disease activity. So if you have a patient with this 573, it is less than those who have 2744. So this may be very useful in follow-up of our patients and to detect if the patient is responding to treatment and how is the response. Although we have this great advancement in the artificial intelligence models, but we have a lot of limitations. These limitations are applicability in routine clinical practice still not widely adopted in every center. And the second thing is lack of validation and issues of insurance. We don't have validation of all systems in all centers in different parts of the world. We have problems with reimbursement of this technology because it's a little bit expensive, and not all the insurance system can approve it. And also the issue of security, because we depend mainly on the computer that can be hacked and information inside it can be destroyed or can be manipulated, so it may give a wrong diagnosis. Over-reliance on artificial intelligence may lead to skilling or bias of data from the machine we are using. Endoscopist diagnosis can be also affected by incorrect AI predictor because it is not as accurate as 100% till today. Lack of data collection from different countries. We have morphologic patterns of the polyps, which may be different. The quality of preparation may be different among countries. We have differences in endoscopic technologies. A lot of endoscopic technologies, a lot of machines, a lot of AI models that are present, and we have to know which one fits each setting and each country and each patient, etc. International validation should be also required before global use of the developed artificial intelligence. Ladies and gentlemen, my take-home messages are: AI, or artificial intelligence, is a rapidly growing discipline that has the potential to revolutionize the field of gastrointestinal endoscopy. AI technology would compensate for humans' limited capabilities, prevent human errors, increase work productivity and efficiency. AI is a fast and reliable assistant to treat the continuously growing number of our patients. AI offers the ability to improve diagnostic accuracy, to uncover new disease associations, to identify at-risk individuals and guide therapeutic decisions making. Continued exploration of possible applications are expected to accelerate the drive toward precision medicine, but there are certain limitations that are still present and needs a lot of research to be addressed before using artificial intelligence. Thank you very much.
Thank you very much, Prof. Muhammad, and please, if you come here, I will open the floor for discussion and questions. Any questions, any comment?
Maybe while you are gathering your thoughts and questions, maybe a question to Professor Lisa with regard to your experience with octreotide, long-acting. Do you think it's working? And what about the GLP-2 agonist in your clinical practice? How effective, and what do you think about it?
Yeah, two excellent questions. Thank you. Octreotide, I'm not a fan. I think if you do get an effect from it, it's quite short-lived. And there are some potential side effects with gallstones, etc. So it would be last in my list of things for managing high-output stomas. I would maybe try it if everything else hadn't worked. GLP-2 analogues are great. We just had them approved in the UK before I left, so we hadn't started many patients on them. But the trial evidence is fantastic. You know, a 20 to 25% reduction at least in parental nutrition requirements, which translates to 1 or 2 nights off per week for patients. And if you talk to patients, having 1 or 2 nights off a week is so important. One of my former patients said that she felt a little like Cinderella, where she could go out and enjoy a party, but she'd always have to leave early to be back to connect up her parental nutrition. So having even just 2 nights off is really important for them. We now have like a once a week GLP-2 analog and maybe some other longer acting ones coming. So it's an exciting time to be involved in short bowel management, to be honest.
Thank you. Any questions from the audience? Dr. Muhammad, with regards to AI in colonoscopy, I have used it actually before. Do you think it's improved the withdrawal time? Does it shorten it or lengthen it? As you know that we need 6 to 7 minutes withdrawal time. If you apply the AI, does it shorten this period or does it prolong it? And what about over detection? Because we see the overdetection a lot. Giving me alarm about, oh, there is something, and we go and just clean, there is nothing. Is it machine learning, overreading, or there is something that we should really just be aware about it and bear with it?
Thank you, Dr. Fad, for your question. Actually, the artificial intelligence models are still all primitive, and we have to stick to the 6 minutes in our withdrawal time. But it can increase the withdrawal time because, as you said, there is some detection of small, non-relevant lesions that can be errors. All the artificial intelligence systems that are present have been studied, and there are a lot of systematic reviews that are coming nowadays which are not recommending those systems as to be a standard of care because they are not as accurate as the original studies that has been published. So I think that still we are in the primitive phase of using artificial intelligence. It can help non-expert endoscopists to learn, to detect lesions, but I think with in the expert hand, it will not make a big difference.
Any questions?
Maybe I just would like to conclude, Dr. Sharif. Making the research is a mandatory part of the fellowship or residency program. You should not graduate or get the certificate without having like a publication or at least manuscript submitted. You think it should be implemented? I know in the fellowship here in Saudi Arabia, GI, it is part of the requirement. But do you think this is healthy to force people to do research, or what do you think?
The short answer is I don't think it should be enforced. It should be encouraged, but not enforced. Because if you encourage research, people will put in more effort if they really like it. And people need to, as I mentioned in my conclusion, people need to have passion for research. And research is not everybody's cup of tea. And those who want to do research should be encouraged, but not forced.
Any questions from the audience? I think we are going to move to the last part of the SGA conference. It is the SGA Awards. So we are going to continue actually, so everyone will be able to attend the prize and the award distribution. So I'd like to invite the SGA panel, Dr. Majid, Dr. Faisal, Dr. Turki. Okay. So we'll continue just after this immediately. Thank you so much. Thank you for the speakers.
Thank you very much.
Thank you.
Assalamu alaikum. So thank you for staying late. And we made a few adjustments in the schedule, so because of that, we thought let's finish before lunch and wrap up the day. خصوصا انه the other room is ongoing. This part is the SGA adores a lot about honoring people, honoring their activities, thanking all the contributions from everyone. We thank you all for coming and attending. We look forward for the next year program. Dr. Majid has his presentation, and then we have some awards and ceremonies that we're going to provide to people, so bear with us. Will not take you that long from lunch, inshallah. Dr. Majid.
Bismillah ar-Rahman ar-Rahim. It's a pleasure and honor to have you as usual throughout the program. We're going to go over a few things that we did this year, the past year, and we'll just share some of our achievements and activities and share with you what's going on in the upcoming year. So success can be measured in different ways. You can look at it in financial sustainability, growth, activities, impact. All of these are different measures of success, and I'll keep that decision up to you whether you see that we're doing well or not. And either way, I think we're doing a good job, and we hope to do better. There's always room for improvement, and we'll see how it goes. One of the cornerstones of the activities of the SGA and what we've done over the years is really invest in our healthcare provider education. These come into different forms and shapes, whether they be courses, symposias, regional workshops, and different activities, hoping to address different needs and demands of the society and the individuals delivering care to our patients. We're going to just go over a few of the things that happened over the last year. Thankfully enough, the GI Motility Group about 2 years ago was established, and they had different activities and workshops. I think the GI Motility Symposium that was done in conjunction with King Faisal Specialist Hospital was one of the biggest events that we had for this group, and then it had a really good impact. The attendance was good, the outcomes were very nice. I think it's increasing awareness about a discipline within gastroenterology that we haven't focused on over the last few years. Another activity, and I think you can see from our sponsors, IBD has become a increasing disease over the years. Appropriate management of our patients, choice of medications, outcomes, and therapeutic monitoring, all of these, and positioning of drugs is a big issue. And the field is advancing so fast that it's even difficult for specialists to keep track of it, rather than even just general gastroenterologists. And then there have been multiple activities. The Center of Excellence, and Dr. Nahda is passionate about this topic and has done a few courses, and still there's more to come. Regional meetings, we've slowed down over the last few years maybe a bit, but this year we had one regional meeting in Mecca, and then it was well received, the attendance was nice. Another activity that we've done over the years and still ongoing, the Best of DDW, usually presenting abstracts, activities, lectures that was presented on an international forum to our local audience. Gut clubs, we've got multiple running gut clubs throughout Saudi Arabia, multiple cities, some of them on a bi-monthly, every second month, some of them on a monthly basis. Some of these have been so old that the Riyadh Gut Club is more than 36 years going on now. So it's even before the SGA was established, which is very interesting. Another activity for the subgroup for IBD, the Crohn's and colitis gut club, Dr. Iman Sles is so passionate about, and she started this activity in the Eastern Province. The IBD subgroup have been doing a lot of activities online. They almost have a monthly journal club online where specialists join, share cases, experiences, discuss papers. And then this has been formalized into another now activity in the Eastern Province. I think the success story of the IBD Masterclass, I think on a regional level, has been a source of pride for us. We did it before COVID once. This was a comeback now after COVID, and it did very well. I think it was a very nice activity. Our trainees have been also a source of focus for the association in trying to elevate their training, supplement some areas that might need more supplementation within their training. There's usually a crash course that's done on a yearly basis for new GI fellows, where people talk about the basics of gastroenterology, emergency management, sedation, endoscopy principles, quality and endoscopy processing, using electrosurgical units. All of these are delivered in a crash course for first-year GI fellows. Also, IBD can be confusing for practicing gastroenterologists, let alone GI fellows in training. And there is also an activity looking at that. I think this is the second year that was done this year, and then hopefully it's going to be on an annual basis. A whole weekend looking at IBD management for GI fellows. And the same thing happened in the Eastern Province. The board review has been going on for a few years. I think we're up to year 11 now. Our colleagues in King Faisal Specialist Hospital have been running this for a while. There's the same thing happening in the Eastern Province, GI review course. So that's for the fellows. Talking about another aspect that's essential for our practice, endoscopy nurses. Over the last few years, we've involved them in multiple activities trying to supplement their skills, independence, even subspecialization into IBD nurses, endoscopy nurses, and helping them in achieving their job and making our lives easier and delivering better care to our patients. There has been 2 courses, one in the Western Province and one in Riyadh this year for nurses. For those who are of you interested in medical education and problem-based learning, there was an activity this year that looked into that aspect, into management in the Eastern Province and, in Riyadh and the Western Province. These parallel courses were problem-based discussions on different GI diseases. I think one of the sources of pride for the SGA is the journal, and we consider it our flagship. At least within the gastroenterology field and maybe in the biomedical sciences, our journal is one of the highest impact journals within the region. I really have to thank the editorial board for bearing with us for this year. I know each time Faisal wants to step down and we keep on dragging him, keep staying as editor-in-chief for our journal. Over the last few years, the impact factor has been going up. This year it dipped a bit, unfortunately, but I think that's part of life. We had a few years of a run and escalating in our impact factor, but it's still, all in all, it's organic growth that's healthy, and we think it's okay. Even looking at the citation indexes and references within the journal, it looks very good. We're still in the 3rd quartile, talking about gastroenterology and hepatology field. And if you look at internal medicine, I think we're in the 2nd quartile. Over the years, the number of citations for the journal is going up. I think we have a better impact over the years. And again, looking at these matrices, they still look good. It is a platform for the region. The most of the contributions come from Saudi Arabia. 2nd line is China. Then looking at US, Canada, India, Egypt. So it's a nice, healthy mix. And looking at institutions, the most submitted articles from institutions represent the biggest centers within Saudi Arabia, which is only natural. From a scientific point of view, this year, although it was published maybe online as an advanced publication, the guidelines for inflammatory bowel disease, which was an activity spearheaded by the group from IBD, it took, I don't know, a year and a half maybe to get this out. It was a contribution between 3 different societies, the Saudi Pharmacological Association, Clinical Pharmacy, and the Ministry of Health, as well as the SGA. These recommendations were very extensive, more than, it's about 73 statements, looking at different areas of management of inflammatory bowel disease. It was evidence-based, it took a while, and I think it was well received, and there's going to be an update to it, hopefully soon. Another guideline that came out this year was H. pylori. We thought this was an area of deficiency, and there were enough publications within the region to make a accommodated recommendation within Saudi Arabia itself. So this guideline also came out this year. Again, our colleagues from the endoscopy area wanted to have a recommendation for quality indicators within the endoscopy units. Again, this was done this year. For the upcoming year, at least we have 2 guidelines that are going to come out for the special populations within inflammatory bowel disease, pregnancy, elderly, oncology. These are coming out soon. And we have another publication coming out, hopefully the group is still working on it, the motility group, looking at care pathways for gastroesophageal reflux disease. From the issues of diagnosis to management, to endoscopic management of reflux disease. So that's in the working at the moment. Community awareness, education programs, multiple activities have been performed. This is just a small snapshot, and I think this is an integral part of the SGA and its activities is engaging with patients and looking at their queries. This year, I think the guys in the organizing committee for the SGA-SDDF meeting did a good job. We're talking about the motility workshop. there was a good attendance to that, the pre-conference workshop. The hands-on for fellows also had a good attendance, and I think it was well received. Another area that the SGA has expanded into is nutrition. And then we were hoping to have a good show up for that activity, and it went pretty well. And we're hoping to expand into the areas of specialized nutrition, whether it be TPN, celiac disease, nutrition and IBD, and different areas of the care of our patients that we haven't engaged in before. So it's another new area that we looked into. I can't judge about the program this year, but I think it was interesting, engaging. From what I've heard, it was well received, and hopefully we'll hear from you later on after the meeting, your feedback, criticisms, improvements, and how you would like to see it next year, and we'll take that into consideration. Again, we had a parallel room next to us looking at nurses. Again, these are an integral part of our care, and then really need to take their hands and work hand in hand in improving their performance. Postgraduate course, again, our colleagues are very passionate about our fellows, and I think it's a well-invested time in the future. For the second year in a row, women in gastroenterology has been another area, and then this year they had interesting concepts. I think females are becoming more intelligent than us in the finances. We're really, we can't really keep our finances straight, so our ladies are going to take over. Let's go back a bit. This, we're going to talk about the SGA being more organized when it comes to not just publishing research and promoting it, but hopefully we're going to have a running arm and operations of research. The IBD Middle East organization is a nonprofit organization that was established with the help of our colleagues from Pfizer. This is a nonprofit company that's based in the UK. The shareholders for the company are from 5 countries: Saudi Arabia, UAE, Kuwait, Jordan, and Lebanon, with representatives of the board from all these countries. They are represented by the specialized organizations within these institutes, and where there is no society, some individuals represent these countries. The objective of this company is looking at operation of research, looking at patient outcomes, running a registry, and combining data from different countries, looking at patient outcomes, and hopefully being a trialist group. We're trying to emulate the different trialist groups in Europe and the US, like the GetAid trial, and hopefully that's going to work. And having a publication that's pertaining to our area in the region. Currently, we have a few funds that are going to be acquired, and we have projects looking at the area of education and training, patient-reported outcomes, translating the ICHM questionnaires in IBD, predictive modeling, looking at different outcomes for patients using different medications, MDCTs, and as well as operationalizing research. The CRO we partnered with is VI Research. These guys started out as a health economic group study, then they went out to be a full-blown CRO, and we're going to utilize these skills to improve our publication platform and research operations. Over the last year, we've had multiple meetings with the company, and we're producing policies and procedures looking at the governance of attending, authorship, choosing research topics, and how we operate this registry. These are minuted, voted, vetted, and criticized, and we hope it's going to change the landscape of IBD research. And although currently we're only working in the IBD forum, we're thinking about expanding this into different areas like endoscopy, motility, and maybe nutrition. We had hiccup with the IBDguide.net. This activity was done a few years ago. This is an Arabic resource for patients to look into with simple language. And people usually, how it worked was you'd engage with a patient in the clinic, give them the therapeutic options, and then ask them to go to this resource, read about it, come back the second visit, and discuss your therapeutic options with them. The website was down for a while. We relaunched it about maybe a month ago, and we're doing a complete facelift for it. And then this resource had a lot of traffic from the Arabic-speaking countries all in all, not just Saudi Arabia, and we still think it's worthwhile. I'd like to thank the attendees. I'd like to thank the members. I'd like to thank these SGA board members. They've been with us for the last few years. They've bared with us a lot of work, effort, and then they've spent a lot of their time and passion. I think over the years we've tried to escalate every year and increase the bar a bit. It's been challenging, but they still keep on surprising us every year that they're doing a better and better job, which I'm really proud of, and I'm happy to be a member of that group. And with that, I'd like to close our annual talk and maybe have our annual award with Dr. Faisal Batwa. Thank you very much.
طيب السلام عليكم ورحمة الله وبركاته. Thank you all for being with us. So it's my pleasure to present the research awards for 2023 from the Saudi Gastro Association. And the third place winner is Dr. ماجد باهدرة جامعة الأمير سلطان في الخرج. دكتور ماجد موجود في أحد من فريقه ما احنا عارفين نوصل له. دكتور ماجد فينك؟ أتوقع أنه سافر. طيب لأنه يعني تعرف مع أوقات الطيران وهذا. The research that was won, that detection factors associated with pre-bleeding stomach lesions and surveillance among individuals with positive fecal local blood testing and negative colonoscopy. It was a 6-year multi-center prospective cohort study from low-incidence central Saudi Arabia. Dr. Majid team. طيب. So I think we'll go for the next second place. الدكتورة لينا اللهيبي تجمع الصحي في المنطقة الشرقية ويستلم عنها الدكتور تركي العميل بالنيابة عنها. The study is about comparative effectiveness of ustekinumab versus vedolizumab in treating Crohn's disease after failure of anti-TNF agents, a real-world experience. ألف مبروك. In the first place goes for that study comparing upadacitinib induction and tofacitinib exposed and naive patients with inflammatory bowel disease. A real-world multi-center study for Dr. إبراهيم العمر مستشفى الملك فهد صالة التخصصي في الرياض. ألف مبروك دكتور، ألف مبروك. To this part, can I have the slides, please? So it's been a pleasure to remember always Allah yarhamu Prof. Ibrahim al-Muflih, one of the main founders of the Saudi Gastroenterology Association, who passed away for a while, but his memory is always will last in our heart. His dedication to this association, to this field of the gastroenterology, the foundation, the build-up in that theme. We always strive to continue to pick and choose and find who served this community of gastroenterology in Saudi Arabia. Over the years, next slide please. Over the years, there is a series of people that the SGA award and acknowledge their contribution. 2014 كان الدكتور عبد الله الغامدي، 2016 كان الدكتور البروف عبد الرحمن الجبرين، ثم بروف 2015 البروف الجبرين، 2016 بروف الجرين، then بروف الفالح، والبروف الجرين والفالح يعتذروا عن الحضور بسبب ظروفهم الشخصية. ثم سعدنا بتكريم البروف يوسف قاري اللي موجود معنا اليوم ويشرفنا دائما بوجوده ودعمه اللامحدود للجمعية. Then الدكتور رياض السبيعي who's a long founder in the SGA, long contributor to our community. And last year we honored Dr. Mohammed Al-Garawi. And this year we wanted to think in a different way. We want to look who developed areas in the Saudi gastroenterology field in outside main cities. You know, when you go in a different area, in a remote area, it's hard to build. It's a real hard work to put an infrastructure, to build a system, to initiate a service, and to collaborate with the different regions in the country. More to that, this person, who is a well-known gastroenterologist in his region, has been a partner in the Saudi Gastroenterology Association board for a couple of rounds when there was zero money. We used to pay for our tickets. So I'm just telling this to the story. I want to share this information to people. In the earlier days, there was really no money. People are paying out of their pocket, paying their tickets, paying their accommodations to get to a board meeting to take some decisions. أنا عندي هنا شاهد على الحدث. كنا نسافر أنا وهو نطلع من جدة للرياض، نقول ليه دافعين؟ أنا في المطار إحنا ليش جالسين ندفع فلوس ده؟ ليه رايحين أصلاً؟ ليه رايحين؟ إحنا معين كلها ساعتين والطيارة تتأخر ونطلع 4 ساعات في المطار رايحين وراجعين. Was a thought. الدكتور عبد الله الغامدي طبعاً أنا أذكره هنا بالخير، يا الله يذكره دائماً بالخير يا رب. It was really hard days. الحمد لله الحمد لله الحمد لله. We're reaping that now. Seeing you all in the room. This is a pleasure that we see. This is a structure that was built over years. Nothing happens in one day. If you want to grab your tree, next day you want to get your fruit. What is this? الرسول صلى الله عليه وسلم يقول إن قامت على أحدكم القيامة وفي يده فسيلة فليغرسها. ليكن ذلك الثيم حقنا اللي نعمل عليه دائما. اللهم صل على محمد كما قال صلى الله عليه وسلم في مجمل الحديث. وهذا هدفنا في الجمعية. احنا نبني. اليوم أسعدنا زملائنا في الأقسام المختلفة وفي الانترست جروبس اللي حنشوفها دحين بتبدأ الرولز دايسنج معاهم، إنه بيبدأوا يبنوا مشاريع مستقبلية. بنشوف الاندوسكوبي جروب كيف إنجازاتهم، نشوف الانترست جروب حقت الموتيليتي حقت النيوتريشن. الآن عندنا في ستراكشرز جديدة بتطلع كلها من بنات الجمعية. احنا قدنا نجحنا مع النيرسينج الاندوسكوبي، هذا يعني صار في تطور كبير في الجمعية. وأنا أعتقد إنه الآن الجمعية في مرحلة من الإيفولوشن تسمح لها تقول إنه إحنا one of the largest associations in this part of the world and one of the most successful ones. productivity حقتنا عالية. أرجع تاني لضيفنا المكرم، ممكن next slide لو سمحت. الدكتور محمد الشمراني who's a consultant gastroenterologist in الباحة, one of the founders للfield in that area. الباحة is a dear city with lots of population. نصهم gastroenterologist، نص الgastroenterologist field جايين من الباحة. لكن محمد جلس في الباحة وقرر يبني في الباحة، قرر يشتغل في الباحة ويتعب على الباحة ويرفع الفيلد هناك، بالإضافة إلى his national contribution. محمد يعتذر عن حضوره اليوم لأنه جاته مهمة رسمية وطنية، اضطر يسافر أمس في الليل، ولأنه دائما قلبا وقالبا معنا. وأنا أدعو الدكتور عبد الله الغامدي إنه يستلم الجائزة بالنيابة عنه.
السلام عليكم ورحمة الله وبركاته. أولا من دواعي سرور أني أقف يعني أمامكم متحدث عن يعني هذا المهرجان العظيم اللي بصراحة يعني ما شاء الله تبارك الله كل ما له في ازدياد وتطور من البداية يعني البسيطة إلى ما شاء الله تبارك الله العالمية. يعني أتكلم الآن أصالة عن نفسي. عام 2014 يمكن أنا أول واحد حصلت على الجائزة، وأتمنى أني بالفعل كنت وقتها أني أستحقها. جهود بسيطة قمنا فيها وما شاء الله تبارك الله استمرت من الأفضل للأفضل. والآن أقف نيابة عن زميلي الدكتور محمد دايل الشمراني اللي يعني كان برضو من أعضاء إدارة الجمعية لفترتين متتالية. الدكتور محمد يعني كان يعني دائما حريص أيام قبل ما توجد اللي هو الاجتماعات أونلاين والأمور كانت سهالة، كان يحجز تذكرته ويحضر الرياض الاجتماعات الجمعية دورتين يعني كاملة. كنا ننزل في الرياض في الفنادق على أساس حضور اجتماعات الجمعية التي كانت تقام يعني كل فترة، وأمور يعني كانت بسيطة والحمد لله يعني الحمد لله آتت ثمارها. الدكتور محمد من الناس اللي كان حريصين على يعني استمرارية الجمعية وتطورها ودخولها في البريفري، فكان من الاهتمام أن الجمعية يكون لها حضور في منطقة الباحة. منطقة الباحة تعتبر من المناطق يعني الداخلية ويعني بعيدة عن الأضواء، فالجمعية استطاعت 3 مرات تذهب إلى منطقة الباحة وتقيم مؤتمرات هناك وتوعية والمنطقة الباحة فيها مستشفيات في يعني في منطقة البادية وفي السروات وفي تهامة، مستشفى المخواة في تهامة، مستشفى الملك فهد في الباحة، مستشفى الأمير المشاري في بلجورشي. كانوا كلهم يحضرون وكان الحضور بصراحة حضور مذهل، كلهم كانوا حريصين. ومن الرعاية الأولية استطاعت الجمعية أن تؤدي يعني رسالتها في تلك المنطقة والأشياء المهمة اللي في مجال الجهاز الهضمي. وزي ما تحدث أخي الدكتور فيصل يعني كلها كانت بأشياء بسيطة وأشياء بدائية، والدعم يعني محدود، وكانت كلها يعني احتسابا لوجه الله سبحانه وتعالى. فالدكتور محمد يستحق التكريم وأدعو الله سبحانه وتعالى أن يوفقه. وهو كان أمس موجود معنا، لكن زي ما تحدث الدكتور فيصل يعني الدكتور محمد كان عنده مهمة وطنية خارج البلد وهي مهمة تعاقد، فالصعب أنه يأجلها، فكان لي الشرف أني أحضر واستلم عنه هذه الجائزة. أدعو الله سبحانه وتعالى أن يوفقه ويوفق القائمين على الجمعية، وما شاء الله تبارك الله مؤتمر ناجح بكل المقاييس، وإن شاء الله يستمر من الأفضل للأفضل بإذن الله تعالى. السلام عليكم ورحمة الله.
طيب أولا يعني أشكركم جميعا على حضوركم. الجمعية تتقدم بجزيل الشكر لكل من قام بأداء وظيفة خدمة لمجتمعه لأطباء زملائه، حتى لو بالكلمة الطيبة، حتى لو بالكلمة الطيبة. أشكر للجميع حضوره. Have a wonderful day, have a good weekend, and time for a collective picture, please.